The topic today is optimal PCI on very calcified lesion. I think the topic is very interesting and beneficial. As we know, the calcified lesion in the PCI is the true or really challenging not only the young interventionist, but also the experienced interventionist, sometimes very difficult to solve. Calcified lesion makes the interventionist very difficult to advance the stand, to deploy fully the stand under expansion or stand regret. Sometimes we met this session or rupture and so on, and for the long time a stand thrombosis. It's very terrible. So I think the topic today very interesting and very beneficial to hear the discussion, the lecture, opinion, comment from the expert from Vietnam and particularly from the US. I am Dr. Hồ Thượng Dũng, resident of Vietnam Society of Interventional Cardiology, Vice Director of Thống Nhất Hospital, Ho Chi Minh City, and I am co-chair by Professor Trương Quang Bình.
Hello.
Professor Trương Quang Bình, the Vice Director of University Medical Center, Ho Chi Minh City, and another co-chair from America, Dr. Thạch Nguyễn. He is very close friend and big brother of all interventionists of Vietnam. Dr. Thạch Nguyễn, he is the Director of Cardiovascular Research Laboratory, Methodist Hospital, Maryville, USA. Academic Dean, Tông Tạo University School of Medicine, Long An, Vietnam. And by now, I'd like to introduce the Vietnam faculty. The first, Professor Nguyễn Văn Tông, Director of Interventional Cardiology Department, Thống Nhất Hospital, Ho Chi Minh City. And the second, Dr. Nguyễn Thượng Nghĩa, Director of Interventional Cardiology Department of Chợ Rẫy Hospital, Ho Chi Minh City, Vietnam. And the third, Dr. Vũ Hoàng Vũ, Director of Interventional Cardiology Department, University Medical Center, Ho Chi Minh City, Vietnam. And last but not least, Dr. Đinh Đức Huy, Director of Cardiology, Chief of Interventional Cardiology Department, Tâm Đức Hospital. By now, I'd like to introduce the faculty from America. Yes, the first of course, the co-chair with us, Dr. Thạch Nguyễn, and the second, Dr. Quan Ly, Associate Professor, Department of Medicine, Associate Chief Division of Cardiology, Associate Program Director, Cardiovascular Director Fellowship, Cardiovascular Self-Healing from University Medical Center, South Tucson, Arizona. And the next, Dr. Rajesh Satyava, Professor of Medicine, Morehouse School of Medicine, Atlanta, Georgia. And the last but not the least, Dr. Gautam Kumar, Associate Professor of Medicine, Emory University School of Medicine, Atlanta, Georgia. And by now, your turn, Dr. Thạch Nguyễn, can you give some remarks? Briefly.
Thank you very much, and good morning, everybody. I would like to, I'm very delighted to be here today. The reason because this is an important and difficult topic in interventional cardiology. So from the US, we have a young team, energetic and overactive. And today, we will have a very interesting and active meeting today with the Vietnamese team. I'm sure the Vietnamese team also young, energetic, and very active. So thank you very much for the invitation, and we are looking forward for this interesting meeting. Thank you very much. I would like to introduce the first speaker, Dr. Kwan Lee. Dr. Kwan Lee is very special physician. I am very impressed. I am practicing in Indiana. I have maybe 4.5 star for the patient for the patient comments about physician. But Dr. Kwan Lee has 4.9 star in many more than 100 comments of patient. It's very special physician, very attending, and a very skillful interventional cardiologist. In Arizona or in Emory or in Atlanta, it's very competitive. It's not easy to be the star. In Indiana, we are people from the countryside, so we are laid back and we don't have any problem. But to be a star in Tucson, Arizona, to be a star in Emory, like a good town, and Rajesh, I feel very impressed with their action and their working skill. And this is why today, because it's a very active, difficult topic in intervention cardiology and new too. So this is why I invite a young team, energetic and very overactive. Thank you very much. And I would like to introduce the first speaker, Dr. Kwan Lee. He is right now Governor, Arizona Chapter, American College Cardiology. Dr. Kwan Lee will give us an overview about PCI in calcified lesion. Kwan, it's your turn now. Thank you.
Yes, thank you very much, Dr. Tak Wen, for that very, very kind introduction. Tucson, Arizona, I think is also the countryside, unlike Emory in Atlanta. That's a very big city. Yeah, it's a real honor and a pleasure to be back with you here in Vietnam. You know, last year we were at the SKY ASEAN Vietnam meeting, and I am sorry that this year that we are not able to be meeting in person again. Thank you, Professor Ho and Professor Trong, for this fantastic invitation on behalf of the Vietnamese Society of Cardiovascular Interventions, as well as all of my friends from Vietnam. As I said before, it's a real pleasure to be here. And it's also great to see my colleagues, my previous colleagues from Emory, Dr. Kumar and Dr. Sachdeva, who are extremely skilled and have done a lot of work in the world of coronary calcification. So I'm going to start sharing my screen here. Okay. So I've been asked to give an overview of PCI for calcified coronary lesions in the space of 15 minutes. And then I think from there, we're going to deal specifically with each of the subtopics. First of all, Dr. Kumar is going to talk about imaging and how to choose lesions to treat. And then we will have very specific left main calcification lesions. And then we're going to be talking about IVUS and OCT, as well as rotablated, et cetera, in calcified lesions. So I'm going to start by just providing a basic overview to summarize the general plan of how we approach calcified lesions, as this is a very complicated topic. And, you know, for each of those subtopics, you can spend a long time, but we're trying to give you an overview here in the next 15 minutes. These are my disclosures. As Professor Ho mentioned earlier, coronary artery calcification is one of the highest and most difficult subsets of coronary intervention, and it presents challenges to the entire spectrum from junior attendings all the way to senior attendings. The picture on the left is based off an English saying that says where you are stuck between a rock and a hard place, as in it's a very difficult thing to deal with, and it requires a lot of skill and advanced procedural knowledge to be able to deal with this well. Give me a second here while I adjust my screen. So we have to ask ourselves first, what kind of special problems does coronary artery calcification pose when you try and perform PCI in these vessels? How do we identify who to use our special tools on? Do you just always use a rotablator? That can't really happen either. what kind of tools are available, when and how to use them. And obviously, as you use all sorts of different tools, there are very specific complications that can occur, and we have to be also aware of those. This next 3 slides are from a paper by Maury H. From Alok Finn and Renu Vermani's group, and probably, in my opinion, presents the best summary of the histology and pathophysiology of coronary artery calcification, and that was published in JACC Cardiovascular Imaging in 2018. As you can see from the series of pictures here of radiography of autopsy studies of coronary arteries, the calcium can exist in many different forms. Not all calcium is created the same. Sometimes the calcium is speckled and in little small sections. Sometimes the calcium is fragmented, and sometimes the calcium is long and diffuse. And all of these specific patterns present different challenges when we're treating them. Generally, speckle calcification comes earlier on in the process of atherosclerosis, and it's not a later phenomenon and does not need to be modified. Here is a even more detailed picture from a micro CT of an autopsy specimen. And you can see here that on this side of the artery, there is a lot of calcium, but the calcium is in nodules dispersed throughout the tissue. And on the other side, you have sheets of calcium. And in general, sheets of calcium or larger gross nodules of calcium is the calcium that we're talking about when we talk about having to plaque modify before we proceed. This central illustration from that article gives you some idea as well as to the entire, how calcium affects arteries in the lifespan of a patient. And you can see that calcium is present early on in acute unstable disease, but when it's present in unstable disease, it tends to be speckled, and so doesn't tend to really affect our ability to perform PCI as much. Really later on, as it goes from micro to punctate to fragmented to sheets, and then starts to form calcified nodules, this is once again the period when we have to start to modify our techniques to treat our patients with PCI. And it's only along this side of it that we also start to see it by either a fluoroscopy or by CT, OCT, or IVUS. And here is when the calcium score starts to rise. And it's important to also know from this that just because a calcium score is high on a CT scan, it does not always necessarily mean that the patient will require special techniques. So as was mentioned before, compared to non-calcified lesions, everything is worse. There's more post-PCI MI, there's more restenosis, there's more target lesion revascularization, there's more dissection during the procedures, ruptures and perforations. There's a higher rate of failure to deliver your stent. There's a higher rate of stent loss. There's a higher rate of balloon rupture, undilatable lesions, under expansion of your stent after you've deployed it with stent regret. And ultimately, all of this converge together to lead to a higher rate of stent thrombosis after PCI. So when we ask the question, how do we predict which calcified lesions may need special therapy with imaging? In some cases, some previous studies have just simply used angiography. They look at the angiogram, they see a lot of calcium, they say, okay, that's going to need modification. The problem with angiography, though, is that it occasionally under-predicts like who needs to be treated. Sometimes you look at the angiogram, it doesn't look to be very calcified. And then when you use advanced imaging, you start to realize that, you know what, it's going to be a lot more difficult than you think. And it often over-predicts who you need to treat. You know, I worked in a center when I first started, a small hospital in the countryside. For many years, I didn't have rotablator, etc. And even in heavily calcified lesions, we would still work and we would still get away with it often. And I'm sure many of you who have also worked without the special tools have found that a lot of times you can actually do your job without having problems. IVUS and OCT is actually ideal in helping you predict, but once again, access to IVUS and OCT and use tends to be lower. And some people argue sometimes that it over predicts. If you just use a single arc, So sometimes you find that there is one spot that has 270 degrees of calcium, but if you don't take into account how long or how deep that area is, you may actually not need to rotablate that lesion. And so the questions that you have to ask are exactly what measurements are you looking at? Is it just a calcium arc? Are you talking about superficial versus deep calcium? In OCT, unlike with IVUS, you can measure calcium depth. So the depth is important, and also the ultimate length of the area that you need to treat. One of the best tests to know whether you should treat something is simply also the failure to be able to pass wires, the IVUS scatter in itself. If the IVUS won't cross, then you pretty much know that you need to do something different, either that or balloon or stents. That's also a good marker of something is trying to tell you that you will need more advanced therapy. So what kind of strategic technical problems will occur in standard calcified coronary arteries? So sometimes, even though you don't have a significant lesion, if you have heavy calcification proximal to the lesion that you want to treat, you may have difficulty delivering equipment distally with an associated risk of stent stripping. So sometimes you still need to rotablate an area to be able to get your stent ultimately to the area that you want to treat. It may be difficult to cross the lesion with the wire because of the calcification. It may be possible to wire the lesion, but then not be able to cross with any devices. And then once you cross and you decide, okay, I'm going to go now, you still may not be possible to fully expand your stents. And that's called stent regret. And then once stent regret occurs, we have to be familiar with techniques of how to bail out and to finally expand the stent that you could not expand. To be able to deal with calcified arteries, you need to have a significant toolkit of equipment. And this includes your standard wires, your workhorse, your hydrophilic. Some people are proponents of the wiggle wire, especially when you don't have a lesion, but you cannot get the device down. And that's the wire that has little bends in it. And so as you push the device down, it doesn't get stuck on one specific spot. I think half the people that have access to it like it, half the people that access don't like it. I personally like it a lot. You need to know your rotor wires if you are a rotablator user, and then Viper wires if you're an orbital atherectomy user. You have to have access to guide extensions. You must have micro catheters for exchange, because rotor wires are not great wires to wire primarily. You tend to need to wire with a workhorse wire and then exchange with micro catheter. To be able to do that, if you have trapper balloons, that makes life a lot easier. If you have CTO balloons, when you're first able to cross, but then your regular balloons cannot get across, sometimes a CTO balloon will just let you get the tip in, and then you can start working that way. Ultra high pressure balloons are important. As you know, cutting balloons are a central device. Scoring balloons, and then obviously because of the risk of perforation, covered stents. And then ultimately also all the devices that you need to deal with perforations when they occur. These are the 4 calcium modification devices on top of what we've just talked about that are available to us in the United States and in Europe. I think in Vietnam, really it's just a rotablator. So, but still, I think it's useful for Vietnam to be aware of what's out there. The primary limitation is really cost. Cost is just simply too expensive. The lithotripsy balloon, which is a fantastic device for us to use, costs $5,000 US here for a single balloon. And if your balloon bursts as you are trying to advance it, or you try and advance it but it will not cross, that cost is still there. And it's just too much, I think, to realistically ask for. So besides the rotablator, you have the orbital. The laser is probably the least useful of these 4 devices, but it definitely has its own niche applications. And then coronary lithotripsy, which has really been, just became available to us over the last several months in the United States, and has been a really helpful tool. So I'm just going to go over, in the last few minutes, several proposed algorithms of how to deal with this. And there are no right or wrong algorithms, and they're all slightly different from each other. But I think they all kind of, have the general principle is correct. Some people may disagree with specific parts of it, but I think they're worth reviewing quickly together. This first version is from Dr. Schlafmitz from St. Francis Hospital. He's a very heavy OCT user. And that is why in this algorithm, there is no mention of IVUS. So it says OCT and balloon uncrossable, okay? So he starts off by OCTing his calcified lesion. If the calcium is deep, he doesn't bother rotoblading, etc. He simply performs a non-compliant balloon to make sure that it will expand, and then he stents it, and then he does a final OCT. If he does the OCT and the calcium is superficial, then he looks at the CVI score, which is developed by Akiko Mehara's group. And if the score is high, if its score is low, once again, they don't bother. They just do a cutting balloon or a scoring or a non-compliant. If the score is high, they then ask the question, is the balloon crossable? And if it's crossable, they do intravascular lithotripsy. If it's uncrossable, they then do rotational atherectomy or rotoblader. Notice here, there's a special category for nodules. If they see a nodule, none of these other things are used. They have to debulk the nodule, and they go straight to rotational atherectomy or orbital atherectomy. And interestingly for this group, before they put the stent, they do another OCT to make sure that there's calcium fracture before they place the stent. So that's an interesting thing that I think a lot of people don't actually do. They do not repeat the OCT after this first rotational atherectomy run to make sure that there's fractures before they proceed. This next version, I think, is from his son because they have the same last name, Evan Schlafmitz from MedStar Hospital. So his algorithm is very similar, except that he does add IVUS. He recognizes, unlike his dad, that IVUS is useful to the thing. And otherwise, the algorithm is quite similar with pretty much the same thing, except that they recognize that you're using IVUS to say deep versus superficial. And then they use IVUS. I think obviously it's just IVUS arc, moderate to severe, and the rest of it is pretty much the same. Okay. And once again, they do repeat their OCT and IVUS after the initial treatment to make sure that there's fractures before they implant the stent. I think that might be unnecessary, but they swear by it. And will be great to hear from the panelists what they think about that. This is the version from Dr. McIntaggart from the National Health Service in Scotland. And their group has done a lot of work on this as well. And theirs is pretty similar. For people with calcified nodules, they definitely recommend rotoblader, etc. And once again, they use, and that's the nodular calcium over here on this line, straight to rotoblader. If you see nodular calcium, once again, if there is very heavy calcification, they do talk about the possibility of non-compliant balloon to start with if the angle is less than 180 degrees. And if it's greater than 180 degrees, they do not recommend going there first. They use rotoblader or shockwave. And then they also image at the end to check before they place their stents. So quite similar, some slight differences. And then this is finally from Manny Brelakis, who I think many people have learned a lot about interventional cardiology from his YouTube series. He's famous for making these algorithms as well. And here, the difference between his algorithm, and this is his balloon undilatable lesion de novo. So this is when the wire crosses, but the balloon will not cross. The balloon will cross, but then he uses high pressure balloons first, then moves to angioscalp cutting balloons or chocolate balloons, and then with the introduction of intravascular lithotripsy or high pressure balloons, he then introduces that idea here before performing atherectomy or orbital or rotational, only if that fails, and then finally laser. This side of the thing is when that happens within the stent, i.e. with stent regret. And as you can see, calcium with stent regret on the inside, that is a different algorithm. They use high pressure balloon inflations first, and then they move to plaque modification, and then they go to intravascular lithotripsy. So intravascular lithotripsy has, I think, revolutionized the treatment of stent regret. It's a much better way of treating than the traditional way in the past, where we use laser bombing, or we would actually rotablate the stent sometimes, to be able to achieve this, and which is clearly not a great idea. And so, yeah, those are the primary differences. So there are, besides that, all the algorithms that we showed you, there are clearly also very special PCI situations, and that's beyond the scope of this talk, but we need to be aware of those, and those will be osteo lesions. How do you treat bifurcation lesions when they're heavily calcified? Chronic total occlusions with the possibility of subintimal dissection around the CTO section and re-entering distal to that. How do we treat calcified nodules? We talked about that. And then also the complexity of treating calcified disease in STEMI and cardiogenic shock, as well as saphenous vein grafts. All those are even more specialized. So to conclude, so that we can listen to the rest of our experts, PCI and calcified coronary arteries can be one of the most challenging subgroups of coronary intervention. Many technical skills are required to perform successfully, and you need familiarity with a wide variety of specialized equipment. There are several well-described strategic algorithms to manage these. But we should argue that in Vietnam, for example, because of the special availability of only some of the tools, that maybe, or maybe this could be a publication from the Vietnamese Society of Cardiovascular Intervention, that there should be a local algorithm developed, as not all equipment is available. The next frontier is all of those algorithms really talk about using the devices as single devices, but how or when should we use the devices in combination? And Dr. Kumar is an expert at this, and he has published his RotaShock series, where they rotablate and then they perform shockwave on top of that. Obviously, for most places, that is very expensive proposition. There has been literature out there in trials where they just did rotablator and then they did cutting balloon before they finally implant their stent. So how do we use these devices in combination, and when should we? And with that, I would like to thank you. We hope to meet in person soon. And these are several pictures I took a few weeks ago from the Albuquerque International Balloon Fiesta. Thank you very much.
Thank you, Dr. Quan Lee. I think that this is a very general, very interesting presentation about the way we manage the calcified lesion for PCI. You give us the general information to do PCI successfully. Especially, you give us 3 points. First, we need the devices for assessment the calcified lesion. The second, to prepare enough the device for intervention, for example, guiding, guide wire, balloon, and maybe rotaplator to do PCI. And the third, the final, you give us at least 3 algorithms in PCI for calcification lesion. I think this is very useful for us, for interventionists to do the PCI for the calcified lesions. And now we go to the discussion part. First of all, I would like to invite Dr. Nguyễn Văn Tân. Do you have any comment on the device to assess the calcified lesion? Dr. Tân, please.
Yes. Thank you very much for your introduction, Professor Trương Quang Bính. And thank you very much for your presentation, Dr. Quan Lee. Very interesting and very overview presentation. I think in the Vietnam now, we have only rotaplator for management for calcification. So I hope in the future we have more device to treat the heavy calcified lesion in the future. For example, the lithotripsy or another one. I would like to give some opinion. So now we in the USA we continue to to the BCI with irididum, local irididum. So I don't know exactly in Vietnam now. So I hope in the future, Vietnam society intervention, also a society can give irididum for continue to BCI heavy with heavy calcification. Thank you. Yes.
Thank you, Professor Nguyễn Văn Tân. And I would like to invite Professor Thật Nguyễn. Do you have any comment on the presentation of Dr. Quan Văn Ly?
Thank you very much. I learned a lot from the talk of Professor Quan Ly, but I would like to leave the time space for the young intervention cardiologists. I have my ideas about calcification in the arteries because one simple thing, after we put a stent in the arteries, the flow is similar to a very calcified artery. So this is why we shave the calcium to put a stent. In hydraulic, it's the same thing as we put another segment of the artery full with calcium, rigid and hard. So this is only my comment. Thank you very much.
Thank you, Professor Thật Nguyễn. Dr. Vũ Quang Vũ, do you have any comment about the tool, the device for assessment of the calcified lesion? How about in your center?
Thank you, Professor Bình. Thank you, Quan Ly, for the good presentation about the calcified coronary lesions. In my center, we use only IVUS. We don't have the OCT in the cath lab, so only use IVUS. And the IVUS we cannot see the thick of the calcium, so that's a problem with the IVUS. So we only do the IVUS and we see what happened with the vessel. But now normally when we see the angiogram, if we have the mild calcification, I think the lesion can be dilated with the NC balloon or scoring balloon or something like that. I think it's enough for the plaque modification before the stenting. If the angiography we have some moderate or severe calcification, we try to do some rotablation or something like that. And Quan Ly, can you share with us some experience about the how to choose the rotablation, rotational atherectomy, or lithotripsy or orbital atherectomy? Your experience about that, how to choose the device when we have some imaging, we have some angiography. Thank you.
Thank you, Dr. Vũ Quang Vũ. I will have one question for Dr. Quan Ly. In my center, we just have the IVUS only. Do you think that we need to have OCT equipment to assess the calcified lesion for intervention?
That's a great question. You know, OCT obviously provides much better volumetric assessment because the pullback is always very accurate. You know, unlike IVUS where the pullback is very rough and you just see one picture. And IVUS sometimes jumps a lot, especially in calcified lesions. As you pull back, it doesn't come back in a uniform fashion, so it tends to jump. And then sometimes you miss something because the IVUS probe went too fast as it got stuck on something and you're pulling and then suddenly it comes back. I find in those situations, it's better to push the IVUS forward, not pull back, to be able to see sometimes because otherwise you miss things. I don't think, to be honest with you, that even though OCT has better depth imaging and thickness ability, that you need OCT to really. There's never been a trial that has evaluated the ability of either OCT or IVUS to accurately predict. And one of the most powerful ways of knowing whether you may have a problem is also the simple inability to push the IVUS probe down. You wired the lesion, you try and push the IVUS and it won't go. You know you need to rotablate that. So that's also a very helpful finding. While the OCT because it's smaller, it tends to be able to go further and it doesn't alert you that way as well. So I think when it comes to cost, etc., I think you can just do it with IVUS. It is good enough.
Yes. Professor Hồ Tường Dũng, I know that in your center you have two systems, one the IVUS system and second the OCT system. When you use IVUS, when we use the OCT for assessment of the calcified lesion.
Thank you, Professor Trung Quang Bình, for your question. I agree with Dr. Quan Lee. When we can recall from OCT, the resolution of the OCT very excellent. So we can see, we can evaluate, assess the calcified lesion very clearly. But I think in the case very calcified lesion, long and diffuse, because the catheter of the OCT very delicate, we cannot advance across the lesion. But in the catheter of the IVUS, I think it's strong because it's over the wire, strong. And so, and another reason, you like to record the good image of OCT, you must evacuate the blood. But in the severe and long lesion of diffuse calcified, we cannot evacuate the blood. And sometimes we try to boost to the distal of the calcified lesion. But when we recall, we can see anything because, yeah, I think so. But so in my center, we have two tools. And if I think that the calcified lesion not very stenotic, we use the OCT. It's very clear and it can give them many information. But in the very difficult case, we often use IVUS.
Thank you, Professor Hồ Tường Dũng. Now it's time to go to the second speaker. It's Professor Gautam Kumar. He's the Associate Professor of Medicine in Emory University School of Medicine in Atlanta, USA. He will give us the topic, Seeing the Plaster and Concrete on the Wall, Imaging for Calcified Lesion. Yes, I would like to invite Dr. Gautam Kumar.
You are on mute.
Hello, are you able to hear me?
Yes, I hear you clearly.
Okay, excellent. Good morning. My name is Gautam Kumar from Atlanta, Georgia. First of all, I would like to thank Professor Ho, Professor Trong, Dr. Wen, and for kindly inviting me for this meeting. Of course, Tak and I have been good friends for a long time. And I would like to thank Tak for coordinating this and for inviting us as well. And it is very good to see my old friends, Dr. Wu and Dr. Hui on this as well. And it has been a long time since we have met, I think maybe in Malaysia live a few years ago and then Singapore live, but it will be good to meet again when we are finally having meetings in person again. Well, I have no disclosures that pertain to this topic. So this is the outline of my talk. I'm going to be telling you about a visual analogy. We'll talk briefly about an overview of different imaging options. Something that's close to us, angiographic assessment of calcium. Then we'll talk about intravascular imaging with the intravascular ultrasound, OCT, and perhaps I will be able to grace the surface on IVUS versus OCT for calcified lesions. And then we'll talk about a case, and then we will conclude. So this is a nice house, and we recently renovated this house, and you can see this beautiful brick wall that you can see on the right side. Very nice brick wall that makes it look like it's like an old factory kind of look with painted over brick, post-industrial era type appearance. But my question to you is that brick wall real? And no, the answer is that brick wall is not real. It is actually just a veneer of brick put on wooden plasterboard. So you see, it is important to be able to see through the plaster and the concrete inside the walls to understand what is actually in those walls and not just look at the lumen, okay? So there are multiple imaging options for coronary calcification, and we will start with non-invasive imaging options. You can detect coronary artery calcification by CT. This is an excellent technique for detecting calcium. Unfortunately, it might not have a whole lot of meaning for us because there's not been much correlation between calcium on CT and need for atherectomy. It can localize the coronary artery calcium, and it can also quantify the coronary artery calcium. You've all heard of Agatston scores that can quantify coronary artery calcium, but this is not the whole artery calcium score that you're given. It is actually a per vessel calcium score that you have to calculate, which may be sometimes helpful to predict what's going on. Coronary angiography can't be great in terms of detecting coronary calcium, but if you do detect calcium on coronary angiography, it is likely to be severe. It can localize the calcium, and it can also quantify the calcium plus minus, not really that good. IVUS is fantastic for detecting coronary calcification. You can also localize the calcium and to a certain extent quantify it. With virtual histology, you can identify the tissue composition in addition to the calcium, and you can tell what is going on there in the tissue as well. Finally, with OCT, you can identify the sharp delineation of the calcified area. You can identify the calcium extremely well, and you can see that localization of calcium is also excellent. So let's talk briefly about angiographic assessment of calcium. This can be classified in this very classic paper by both Mintz and Tusu from 95 and 96 that really hasn't changed a whole lot since then. You can classify it as none or mild, moderate where you have radio opacities which are noted during the cardiac cycle before contrast injection, and severe where radio opacities are noted without cardiac motion before contrast injection, but it compromises both sides of the vessel lumen. And when you compare this definition with IVUS, the sensitivity is about 50% of angiography, both according to the Mintz article and the Tusu article. And in the Mintz article, severe calcification by angiography had an arc of at least 238 degrees. The definition that was used for severe calcification in the more contemporary era, which is the Orbit 2 definition in the Orbit 2 trial for orbital atherectomy, was an arc of 270 degrees. And that reflects transition from the era of angiographic assessment to intravascular imaging. So the calcium is definitely out there. This is from the survey of angiograms done in the United States. The calcified lesions, we are averaging about 30%, maybe higher calcified lesions. So the calcium is definitely out there. Even in ACS lesions, this is pooled data from almost 7,000 patients from Acuity and Horizons AMI. And you can see that as the amount of calcification increases, as Dr. Lee alluded to earlier, not just the procedural complications go up, but also eventual risk of death, cardiac death, MI, TLR, and MACE also start to go up as well. So that becomes a very important thing to appreciate. So in terms of intravascular imaging, we can look at IVUS, which is on the left. A, B, and C, and OCT, which is on the right, which is D, E, and F. And you can see here that the arc of calcium is being identified. In the first image, there is very mild amount of calcification. With moderate calcium, it is about 180 degrees of calcium in both these images, and you can see it both on IVUS and OCT. With severe calcification, you can see an almost 360-degree arc of calcium. In addition, now the last two images, C and F, I would like to draw your attention to. And if you're able to see my pointer, you can actually see here that at this point, this is the leading edge of the calcium, and this is then followed by an acoustic shadow. Now, on the OCT, it is able to penetrate through this, and you are able to assess the thickness of the calcium. And this is something that Professor Ho alluded to a few minutes ago as well. In terms of the IVUS assessment of calcium, you can look at this, and these are details from this paper. This can be classified, it looked at a huge number of lesions, and about 300 of them had moderate calcium, 130 of them severe calcification, and a large number of them had target lesion calcium. So in general, we tend to think about these calcifications as the arc of calcium, the length of the calcium. Now, length can be a little tricky if you're doing manual pullback on your intravascular ultrasound. However, length can be easy to assess if you're using a pullback sled with the Boston device, for example. The distribution of calcium is an important thing, superficial versus deep, lesion associated versus reference. So that's also important because that's going to tell you what you're going to do. And as Dr. Lee alluded to earlier, you may have a lesion that is not very heavily calcified, but you may have a heavily calcified proximal segment that may cause you trouble in delivering devices to the target lesion, which can cause problems as well. And finally, it's important to understand whether the thickest calcium or the area where you have calcification is concordant or discordant with the plaque thickness. And IVUS can tell you this as well. The importance of this is that if you have calcium that is opposite to where the worst plaque is, this may not be very well ablated by the rotational atherectomy device because of the discordance between the discordance between the compliance of the two areas. So there are some issues there as well. In terms of the OCT assessment of calcium, we can think about multiple things, and this is a scoring system that Dr. Lee again alluded to earlier. You have the maximum calcium angle, whether it is less than 180 degrees, you get 0 points, more than 180 degrees, you have 2 points, maximum calcium thickness, less than or equal to 0.5 millimeters, 0 points, more than 0.5 millimeters, 1 point, calcium length, less than or equal to 5 millimeters, 0 points, greater than 5 millimeters, 1 point. And if you score the higher on this, the worse you're going to get. And let's examine this. They looked at a test cohort of 969 patients, and it ultimately came down to 128 patients with a calcified lesion with whom they validated this algorithm. And then they looked at a validated cohort with another 133 patients with a calcified lesion. And these 133 patients, as the thickness of calcium, if it was greater than 0.5 millimeters, stent expansion was less than 70% in 10%. Now, if you think about it, stent expansion less than 70%, 10% is not that bad. But on the other side, when the thickness of calcium wasn't high, it was 0%. And again, when the calcified segment was long, which was in 57 patients, stent expansion again was less than 70% in 17%. Again, on the other side, when it's less than 5 millimeters, stent expansion less than 70% was not there at all. Finally, if you look at the angle, if it is greater than 180 degrees of calcification, again, about 30% of these patients had inadequate stent expansion, whereas if the angle was less, then you had a better result. And this is actually an image that shows you some of these issues, where you can see that if you have minimal calcification, you have very good stent expansion, you have a nice round stent that we like to see. But if the moment you start having worse calcification, you have a longer arc of calcium, even you start seeing that with the calcium scoring system that we talked about here of 4 points, you see that stent expansion goes down to 68%. So it's important to realize that with OCT, you can actually really quantify and assess the calcium. So what about IVUS versus OCT? This may be of interest to Dr. Lee. The sensitivity and specificity of angiography to detect OCT calcium, any OCT calcium, was 50%. And the sensitivity of angiography to detect IVUS calcium was also around 50%. So yes, they lined up pretty well in that regard. All cases with OCT detected calcium were also detected by intravascular ultrasound. Good news. 4 angiographically detected calcification cases were actually missed by OCT. And believe it or not, gentlemen, 1 was missed by both OCT and IVUS. So sometimes calcium can be missed by both as well. So that I thought was interesting. But the good news is IVUS and OCT appear to be pretty interchangeable because the OCT and IVUS calcium angles were pretty similar. And they were really only different by less than 10 degrees, which is not clinically significant. Now, OCT can often be used to measure calcium thickness, but it is important to realize that when you have superficial and deep calcium in the same area, like you're looking over here, this asterisk marked line is actually here, and there's a calcified area below it, but here you can't tell the depth of the thickness of this calcium at all because of the calcified area below it. So there are scenarios where deep calcium can be missed if there is superficial calcium, even by OCT. So finally, I would like to give you a little comparison of IVUS and OCT for calcified lesions. The presence of calcification can be identified both by IVUS and OCT just as well. The arc of calcium can be marked by either technique just as well. The type of calcification, IVUS and OCT can often be used to identify whether it is superficial or deep. OCT tends to be a little better in identifying it. IVUS, if you have calcium, sometimes it can be hard to tell because of the acoustic shadowing. Length of calcium on IVUS, yes, you can identify if you use an automatic pullback sled or you use co-registration. On OCT, yes, the length, you can always identify it. Thickness of calcium on IVUS, usually no tell because of the leading edge will cause an acoustic shadow. With OCT, usually you can tell. More often than not, you can easily tell the thickness of the calcium. With IVUS, contrast use is not required. This is an important thing to note, especially in renal failure patients. With OCT, contrast use is definitely required. And I bring up renal failure patients because these are, again, the same patients who have kidney disease, who also have significant calcification in their arteries as well. So unfortunately, that kind of travels together, and it's important to mitigate contrast use on these patients to prevent CI-AKI. In terms of aorto-osteal lesions, IVUS can work out very well. With OCT, sometimes it tends to be okay. You may need to use an adjunctive guide extension catheter or other techniques to optimize the image, but IVUS is a lot more reliable in this scenario. Now let's look at a case. This is a 69-year-old male who was referred for cardiac evaluation for carotid endarterectomy. He had no angina, he is sedentary. He had a stress test that showed a 15% defect. He has diabetes, hypertension, hyperlipidemia, and is a current smoker. So all of these are calcium risk factors for having calcification in the coronaries. And this is his coronary angiogram. I would like to play through that and maybe ask the panel or anybody, actually, a couple of opinions on how many of you would, we'll let that play for a second, and you can see that there is that LAD lesion. Would you want to do balloon and stent it? Would you do a FFR? Would you do an IVUS? Would you do an OCT? Or would you do, you decide to do atherectomy with balloon and stenting? Can we maybe get some opinions if you have a second?
I think we make the IVUS before the pre-PCI for the LAD. because very important, because only the total occlusion of the left surf, and you see the hazy of the, when you do angiogram, we see a hazy in LED. Maybe it is the calcified, moderate calcification in the LED. So I think you need to do the IVUS before we do the PCI in this case. In my opinion only. I'm Dr. Nghĩa from Jarai Hospital. Yes.
Gautam, I would probably do an IFR with co-registration just to understand which areas need to be treated, because it's quite diffuse, and it's possible that you might need to treat more than the just focal areas, and then IVUS it to understand the calcium, etc. And then based on the IVUS, decide if I need to rotational atherectomy before PCI.
Yeah.
Okay. All right. So everybody says we have to do FFR. So here is your FFR.
IFR.
FFR was 0.75. The back of it from the blue line onwards is the pullback. And that was basically from around here to here is where you get this drop. It was a pretty quick pullback. So then we decided, I will show you the angiogram one more time. And again, angiographically, you know, I can't say I was terribly impressed by the amount of calcium, but there is some there. And so then we did intravascular ultrasound with the poor man's co-registration. And you will see this is my co-registration image for you. And there are areas with severe calcification, mild calcification, severe calcification again, moderate calcification, and no calcification with a relatively clean disease segment. So in this case, you know, we elected to perform atherectomy since there were areas of severe calcification that we wanted to maximize our stent expansion. And we decided to do orbital atherectomy in this case with Diamondback. And we did 80,000 RPM with 4 passes in the more proximal part of the lesion, and subsequently in the more distal part of the lesion, so total 8 passes. And subsequently, we then used a specialty balloon to balloon it, and then deployed a stent in this 2 stents actually. It was actually a longer lesion, and so we had to put 2 stents. And I tend to post-dilate these pretty much empirically, and so we post-dilated it nicely. And this is our final result with MSA of 8.5 in the proximal LAD and 4.2 more distally in the mid LAD. So in conclusion, angiographically inapparent calcification is a real issue, like in this case, that can affect PCI success. It is essential to rely not just on a luminogram and look at the plaster and concrete in the walls. OCT or IVUS imaging is essential in these cases to optimize PCI results. Thank you very much.
Thank you, Gautam, for an excellent lecture for of imaging IVUS or OCT for calcified lesions. I think based on what you presented, we know that not only the angiogram can give us the details of lesions, but with IVUS and then OCT, we can look more clearly, and then the operators can have a better idea to how to treat the lesions. So can you share us some experience of, do you believe that if we have imaging guided PCI, then it will translate to better outcomes of patients after PCI, even in stable angina or in acute coronary syndrome?
So yes, the strategy of IVUS guided PCI has been studied in the ultimate trial that you're familiar with outside the United States, and that has been shown. We are awaiting the results of the Illumian 4 study for OCT, which we will have a better perspective on OCT guided PCI. Now, there is also ongoing US trial, which is known as the IMPROVE trial, which is again IVUS guided PCI versus angiographic guided PCI. I do personally believe that imaging guided PCI tends to produce better outcomes even for non-calcified lesions, but definitely in calcified and complex PCI lesions, left mains. These are all lesions that you should probably definitely use imaging. To actually make things more cost efficient, I think it is definitely important to consider imaging in the more complex lesions that you're doing, not necessarily in the simple type 8 lesions where you're able to put one stent and call it a day. So I think that's probably how we can use these tools and optimize PCI.
Thank you. Dr. Rajesh, how about your opinion of applying imaging in routine daily practice? In Asia, Japan is a country that's IVUS, I think, very often in PCI. In some of the stopped up clinical trial from Japanese doctors, nearly 100% of PCI procedure was guided by IVUS or OCT. How about it in US or especially in your center?
So we are very heavy on using intravascular ultrasound and OCT in our PCIs. I think in US, penetration of IVUS and OCT, I think back in 2010 was somewhere in the range of 9 or 10%. I think that number has probably gone around maybe 18 or 19% now. I think there has to be, we have to do better. I think imaging definitely improves outcomes. Imaging gives you things you probably don't sort of think. And on top of that, I want to throw is that you can do a post-stent FFR. If you've done a pre-stent FFR and you've treated the lesion, you can do even a post-stent FFR, and that can also predict your outcomes. There is value to all these technologies which are there. Now, cost is a big issue, and I can understand in Vietnam how this can be implied, as Dr. Kumar said. I think the best sort of return for this cost would be to use this technology in patients who have a complex disease, where you will have, I think, the best utility of this technology to help you improve outcomes.
Yes.
Thank you. Dr. Nghĩa,
I would like
in Chennai Hospital.
I have one question for the Dr. Kumar. Yeah. Dr. Kumar, I have asked you one question.
Yes.
When because you present your presentation very interesting. When you compare with the OCT and IVUS, when you do the PCI, which is the tool you prefer to use in PCI in your cath lab or in US? Yeah, because in my cath lab I only use the IVUS only. Yes.
Thank you very much for that great question. So I believe that it should be individualized to the patient that you are dealing with. If I have a patient who has chronic kidney disease, and we have a creatinine of say 1.4, 1.52, or then in that patient, I think OCT is probably not a good idea, because you want to minimize contrast usage for that patient. That is the patient that I would consider doing intravascular ultrasound in. Now, we have been experimenting and doing some work with saline-based OCT without giving any contrast, but that remains in the realm of research and investigation. It is not mainstream practice as of now. In general, I would say that we tend to use intravascular imaging for close to 90 to 95% of our patients. And out of this, I would probably say about 1/4 of this would be OCT, and the other 3/4 would be IVUS in our practice. So we are still heavily IVUS dependent. We tend to IVUS in the beginning if we are able to cross. We tend to IVUS after we do atherectomy and stenting to assess the adequacy of what we have done. Especially with shockwave, it's important to assess for whether there is calcium fracturing, because that determines whether you're going to be able to deploy a stent and expand it to its full expansion afterward. And after we do that, we also typically go ahead to look at stent expansion and apposition as well.
Yeah. Okay. Thank you. Thank you, sir. Because
Okay, so
yes, because in I think in US you had a high resolution the IVUS. So either if compared with the OCT, high resolution IVUS is the same quality and same for you quantity, the calcified plaque when we do the PCI.
So if for the purposes of calcified plaque, I think for those purposes, I think OCT is still probably better. We have limited experience with high resolution IVUS. Most of the time we tend to use the 20 Hertz eagle eye platinum catheter. We have some experience with rotational IVUS that we have used, and it does provide better resolution, but I don't feel like it makes that jump to the level of resolution of OCT. And if you look at the resolution, OCT's resolution compared to high resolution IVUS, even with the really high 45 megahertz catheters, is actually still better with OCT, and it's an order of magnitude of around 10-fold. So I think at this point in time, if you're looking at resolution alone, OCT is probably the best. But if you're looking at both practical use, if you're thinking about speed, if you're thinking about minimizing contrast usage, I think regular IVUS catheter, not even HD IVUS, but just regular IVUS is probably adequate. If you have HD IVUS, that would be fine.
Yeah, thank you. Thank you, sir.
thank you, Gautam. Thank you, Dr. Rajesh, for discussion in this topic. So I think we are 10 minutes behind of the program. So let me introduce the next speaker. So the next speaker will be Professor Hồ Thương Dũng, the president of Vietnamese Interventional Cardiology. So his topic will be the optimal PCI for left main calcified lesions. So Professor Dũng, please share your screen.
Okay, thank you so much for your presentation, Dr. Đinh Đức Huy. Can you see my presentation?
You see it.
Yes, okay, see.
Yeah, thank you.
Yeah.
My presentation present one case, I think a little bit special. I remember in the presentation of Dr. Quan Lee, you have one slide talk about special situation in BCI in calcified lesion. And I have one case, but out of your slide, I have one case, very old patient, elderly, 91-year-old male, and cardiovascular risk factor, hyperlipidemia, hypertension, diabetes, ischemic stroke. And the patient were admitted to the local hospital, Cần Thơ City, with the diagnosis very high risk non-STEMI. And the interventionist, he is the young fellow from world trained from my center, called me for a referral. Triple vessel disease with the left main disease. And the patient very old, he refused bypass surgery. And so he referred the patient to our Cadillac. Medication, enoxaparin, aspirin, clopidogrel, atorvastatin, bisoprolol, nitrate. It's easily not special finding QY in the inferior area. Laboratory examination, we have the cardiac angina, high sensitivity troponin increase very high, and pro-PNB increase very high. But the echography, ejection fraction, so on. And before the patient come to our hospital, I receive the coronary angiogram from provincial cath lab. And you see CTO in the right coronary artery. And we can see the very calcified in the lab. And in the lab, you can see very calcified with large burden in the distal lab main involved to the ostium of pole of LAD and circumflex. And one thing more, very important thing, we can see one aneurysm in the mid LAD, in very calcified and very stenosis in this area. You can see here. Yeah, we can see the aneurysm. So what can I do? I think it's the special situation. Dr. Kwan Lee can give more. So the first, we do the interpretation of the coronary angiogram. Last remaining vessel is mean CTO in ostium right coronary artery. Heavily calcified distal left main involved pole of ostium of LAD and circumflex. Heavily long calcification along distal left main osteoproximal mid LAD. And particularly in combination with an aneurysm in severe stenotic calcified segment in the mid LAD. It really very difficult complex case of very elderly 91 years, and he refused the operation for a long time. And I think it's very naturally and or reasonable if I can get the DA 90-year-old. One day some young interventionist come to meet me and ask me to operation. I refuse. Yeah, I think it's naturally. So can we do that? Can we do something? If yes, how can we do that? Yes, we very familiar with the algorithm, very severe, so we must atherectomy. And by now, as you know, we have some selection criteria. It's the list, this difficult lesion, moderate difficult lesion, and most difficult lesion. This patient belong to the most difficult lesion, long calcified. I think at least 30 millimeter, heavily calcified, significant, and so on. And one more, the complexity of the bifurcation PCI depends not only on anatomy of the bifurcation itself, but also on the whole of coronary artery tree. And we have the phenotypic classification of complex bifurcation. The two bifurcation were defined as important localization. You can see the lower important localization of the bifurcation is mean the distal left main or some position supply in for a large amount of myocardium. And plot with red the one the following. One, heavily calcified bifurcation such as this case. Two, sequential tandem bifurcation, it means a 2 or 3 bifurcation sequential. 3, critical stenosis lesion nearby. 4, triple vessel disease, such as this case, triple vessel disease. 5, small diffuse disease, as you see, diffuse and calcified tortured LAD. Thrombus containing lesion maybe because the distribution non-STEMI. Repeat revascularization, no, this case. But not remaining vessel in this case because CTO in the right coronary artery disease. Trifurcation and quadrifurcation, no. So I think this guy very complex bifurcation. And according to 2020 SKY consensus or complex bifurcation BCI, it means anatomy, comorbidity, and we need equipment. How about equipment in Vietnam by now for complex bifurcation? Intravascular imaging, intercoronary physiology, FFR, IFR, guide catheter extension, a special coronary wire, special balloon, cover stand, atherectomy, rotablator, OAS, lithotripsy, embolic protection device, and mechanical circulatory support. In Vietnam, we have IVUS, we have OCT, we have FFR, we have IFR, we have the Myrocat, we have a special coronary wire, special balloons, cover stand. We have a rotablator only. And we have a filter wire, we have a balloon pump, we have an ECMO. And what can we use this tool in my patient? Plan to do the BCI with a strategy. The first patient have a heavily long calcified with large burden along this development to the LED. Should we use the cutting balloon or scoring balloon or rotablator in Vietnam? The second, heavily calcified distal ligament involved pole of ostium of the LED and circumference. So we must stenting distal ligament, provisional stenting side branch technique or intentional two stent technique. The third, in combination with an aneurysm of severe stenosis calcified segment in the mid LED. So aneurysm is the contraindication for atherectomy of balloon dilatation. So what we can do? We do occluding aneurysm. If we do with the technique being done first, or we do separately stage BCI or simultaneously, it means we do calcified lesion in the same time with the occluding aneurysm. And the patient last remaining vessel, CTO of ostium CA, do we need mechanical cardiac support? I like to hear some advice and some comment from panelists. My presentation have 20 minutes and with 10 minutes for discussion. Can you give me some advice?
Yeah, so Professor Young, that is a fantastic, extremely challenging case. I think it would be extremely challenging for whether it's US or Vietnam. So congratulations for taking it on. I think if this was done in the United States at my center, we would definitely do this with mechanical circulatory support. There's just too much at risk. Especially if you only have a rotablator and there's a risk of no reflow and dissection, there's just nothing to bail you out. So we would either do that on impeller support or we would do it with ECMO. I did exactly a case like that, 91 years old as well, but we did it with ECMO, and we used orbital atherectomy along both lines. Definitely, we would use IVUS to pre-plan our case and to understand exactly where we would place our stents. I would definitely not try and do the mid-LED at the same time. I think it's much more important to re-establish flow into the left main, stabilize the patients, and then it give you a lot of options to come back later. One thought is to actually start with the CTO of the RCA. If the CTO is crossable and you can revascularize the RCA, you immediately make the procedure a lot safer. Clearly, you don't want to try too long, but sometimes, as we all know, there is going to be no harm to try. As we all know, if you start off that way and you get across, then you are in a much better place when you're working on the left main LED. I think I would probably use IVUS to understand whether I need to rotablate into into just one branch or both branches. I think that's an important statement. If you do it without revascularizing the RCA, you obviously want to do it as fast as possible. So some of the techniques like DK crush, which tend to take a bit longer, may not be the best technique to use if you want to go very quickly. And you might want to use a provisional stenting technique, pick the best branch, and then use a tap as bailout or a culotte as a bailout if it doesn't work very well. Yeah, I think that's generally, and in the US, if I can help it, one of the strengths of having a lithotripsy balloon is that you don't have a risk of no reflow or embolization. So I did a case quite similar to that the other day, but I used lithotripsy in both branches instead of using rotablator, and we were able to get away without having to use mechanical circulatory support. You know, so yeah, and I look forward to the thoughts of my other colleagues. Thank you.
Okay, thank you so much, Dr. Kwan Lee. By now we have just only IVERS, OCT, rotablator.
Yeah, Dr. Kumar.
Yeah.
Yeah, Dr. Kumar looks like he wants to say something.
Dr. Kumar.
Professor Ho, this is a very, very difficult and challenging case that you are proposing to the panel. I think definitely in the United States, I agree with my colleague, Dr. Lee. We will definitely do this with mechanical circulatory support at our center. I also agree. In fact, I think we have a fairly similar case to this coming pretty soon as well. Without the aneurysm, of course. The aneurysm always adds another measure of complexity to your case. I think it is reasonable to try and see if we can cross the RCA CTO. If you're able to cross the RCA CTO, especially if you can cross it just antegrade, that would be beautiful, because that would decrease the mass of myocardium at risk. And you may be able to subsequently consider the rest of it without MCS. That could be a reasonable strategy. Or you could say, okay, you know what, I'm going to use mechanical circulatory support with Impella or ECMO, as you may have, and say, okay, I'm going to go for the left main LAD first. I'm going to wire both, rotor both, stent both, secure that left main. I agree with Dr. Lee that the more intensive techniques, such as performing DK crush in that left main, or even culotte with multiple rewirings, is going to be problematic. We tend to prefer a modified mini crush technique in this kind of scenario, with stent in the main branch position, stent in the side branch ready to go, and deploy the side branch stent, pull back the balloon and the wire, deploy the main branch stent immediately. Followed by rewiring, kissing, etc., to kind of expedite this and potentially decrease the risk for destabilization of the patient while this is going on. It's important that we do rapid PCI, because even with mechanical circulatory support, that doesn't mean that the patient cannot destabilize, and we've seen that sometimes as well. Thank you.
Thank you, Dr. Kumar. Maybe some comment.
So I think given the limitations of what equipment you have in Vietnam, I think what I saw that you have ECMO support, you have rotablator, and you have all these stents, balloons, and the wires. I think I'm going to sort of differ with my colleagues, and I think, since you have an ECMO support, you can take your time and you can actually do both the left main LAD circ lesions, and then also finish up the mid LAD lesion. Coronary aneurysms, they do not rupture, so I won't even worry about the coronary aneurysm. I will stent across it and hope for the best that I don't jail any other branches there. I would not use covered stent for those coronary aneurysms. So that would be my sort of approach. And I think if I have to rotablate, I will use a 175 burr. I'll make sure that I rotablate the left main, I rotablate the LAD nicely to get a good expansion of my stents. And I just have to have another look at the circ. If there is a tight disease, I may do a rotablade first, the circ, and then go into the LAD and do the rotablation of left main LAD. So I have my wire there in the end, and then wire the circ later on. So that would be my strategy. And with ECMO, I think you have support. You can take your time and finish the patient. I think ECMO gives you that much liberty to it.
Okay, thank you so much, Dr. Rajat. Different opinion. Yes, this is my strategy, my plan to do BCI. First, I open distal abdomen with post-proximal segment of LD and circumflex, but not include segment with aneurysm. And the next step, if everything okay, I go to open the segment with occluding the aneurysm. We use the coil. Dr. Rajesh suggests a cover stand. When I perform, and I don't open from the right coronary artery because very high level of troponin and high antiprotein B, and when we can see from the OCT to the retrograde collateral, it's a long way. So we go to do the distal abdomen first. So this is some slide. I present my case. The first BCI, I have a plan to do the BCI to the distal abdomen to open for the left coronary artery. You see, very severe and tortuous and calcified along the proximal abdomen to the mid proximal LD to the mid LD. I wiring difficult. Wiring very difficult. And when I wiring successfully, I use the small balloon 1.25 and 1.5 short balloon to open to exchange the rotor wire. But when I exchange the rotor wire, the microcat cannot cross the mid segment of LED because it's very calcified and very strict stenotic. So I must go directly wiring rotor wire through the microcat, go to the distal LED. And by now, I do rotor bladder with the small burr because I'm afraid it's something. And I rotor apply distal abdomen, ostium proximal segment of LED and stop before the mid segment with the aneurysm. I think it's better. And with the strategy, the first I choose, maybe I try to keep the visual stenting side run technique, but when we do the rotor bladder and we dilatation with the balloon, the ostium of the circumflex not unstable. So I must do two stent technique with the cross. Some dissection of distal abdomen is okay, no problem. stenting to the circumflex first. After we do the PK cross technique successfully, we have a stent regret. As you see in the proximal of LED, the stent cannot under expansion before the curve. How we can manage stent regret? We use the balloon 3.0 at 3.12 inflate with the atmosphere 24, 26, and the last is open. Kiss the balloon again. Many stent regrets. You can see stent regret very clearly. 3.0, 3.5, 8 or 12 millimeter. So we have the final result of the first PCI, I think, very successfully. The patient feel better. And the aneurysm of mid-segment of the LED stable. So 6 days later, I asked one neurological interventionist help me to coiling the aneurysm. You can see we try to coiling. Rather difficult. After 2 or 3 attempts, we can coiling successfully. After coiling, we have confidence to dilatation of the mid-segment. Preparing for stenting. We must use the extension catheter to bring the stent to this area. You can see Hidezilla. Yes.
The final.
POT, and BOT. And successfully final result. So I think this is a special situation, Dr. Kwali, give more your presentation.
Professor,
in combination with aneurysm.
Yeah, that is more than special.
We have IVERT, we have OCT, but we cannot recall it because very severe. After we stand in the OCT catheter, we don't have, so we use IVERT. The IVERT cannot go. So the take-home message I have after this case, coronary artery of the elderly often very severely few taught to us calcified, particularly type C bifurcation, Lachman, triple vesicular or CTO. PCI in elderly require advanced techniques and assistance with the instrument dry tone. Revascularization in the elderly should be modified. In the case challenge Lachman case, many stage PCI, it means you can do 2 times or 3 times, particularly at very high procedure risk. Aneurysm in association with the calcified lesion is very difficult lesion. Atherectomy is associated with occluding aneurysm can be considered, but I have only one case, so I can give the conclusion. Thank you so much for your listening.
Thank you, Professor Young. That was really spectacular. And I noticed that you did it without either a IBP or ECMO.
Yeah, I have a one. I have a balloon pump
Ready?
in heart, but we don't give inside because we give only one vascular asset in the right femoral artery. But in this case, after we have the right asset in the femoral artery, the femoral and the iliac artery dissipation very tall to us. We cannot use in the right. We must go to in the left to do PCI. So I don't know if something happened. I have no asset to go to give a balloon pump.
Yeah. Yes.
A little bit high risk. Yeah.
If you would like to do the mechanical circulatory support, you need you the VA or the impeller only, because the patient is very old. The tortoise, the arteries, so difficult for you to push the IBB, and sometimes dangerous for the patient. Yes.
Yeah.
I think that we should try to do RCA first because maybe it's the situation. We have a collateral from the left to the right, but sometimes maybe at first very severe stenosis at the RCA. Now it total occludes. We need to try to do RCA first. If we fail, we come back to the left. It's maybe safer than we directly go to PCI for the left.
Yeah. Okay.
Okay. Thank you.
With you. I would like to ask you one question about us. Is it the aneurysm in the mid LAD? It need or no need to coil the aneurysm or not? Because the coronary aneurysm maybe last longer, no effect any for the patient. Yes. But sometimes we can use the stand. We can stand. After we stand, in my opinion, my experience, in this case like that, after that we deploy the stand. After stand, maybe sometimes, most of the case, the aneurysm disappear.
Yes, I think so. I think because the first we must manage the region, because in this region very calcified and very severe stenosis in the mid segment of LAD. And I'm afraid if you use the cover stand very, very hot, and you very difficult to give that, given this very stenosis region, you must dilatation. If you do the dilatation, it rupture because aneurysm large. I think so. So we must coil first. After we coil successfully, I have a confidence to continue to do open.
Yes, thank you.
Yes, I want to have a comment, a question for Dr. Kumar. I think with aneurysm, we worry about the thrombus in the aneurysm, formation thrombus in aneurysm. We don't worry so much about the rupture of aneurysm. So in this case, maybe we don't need to coiling the aneurysm. How about your opinion?
Yeah, these aneurysms are complicated. In our experience, I have probably done probably about 8 to 10 PCIs on coronary arteries that have had aneurysms in my career. Because we at our hospital, we have this Veterans Administration hospital. A lot of our patients belong to the older generation. So atherosclerotic aneurysms tend to be more common. To answer your question, we have not felt that thrombus there was a major issue, especially for a small aneurysm like this. Thrombus is a bigger issue if the aneurysm is larger. Rupture, we're not very concerned. I have done rotational atherectomy past these aneurysms. Fortunately, given the fact that if it is saccular, you're in the main vessel and you're actually quite far away from it, and stent across it with relative impunity.
Thank you.
Okay, that was a great discussion. I think in interest of time, we need to move on to the next lecture. Fascinating case. Thank you for sharing, and thank you for all the expert opinion. Well, many different ways to approach that one. So the next speaker we have today is Dr. Vu Hoang Vu. Hopefully I've pronounced that correctly. Unfortunately, I haven't learned Vietnamese despite having gone there for many years. He's currently the director of Interventional Cardiology Department at University Medical Center in Ho Chi Minh City, and is a member of faculty at the University of Pharmacy and Medicine at Ho Chi Minh City in Vietnam. And he will be speaking to us today about IVUS in optimal PCI for calcified lesions. We look forward to his talk. Thank you.
So thank you, Wan Lee. Today my lecture about the IVUS guidance for calcified lesion PCI. So this is the algorithm for the calcified lesion by euro intervention. When we see the angiographic calcification, if it is mild, we just use a balloon. For example, scoring balloon or cutting balloon is enough for the optimize the result of stenting. But if we see the angiographic calcification by the angiography, if the calcify is moderate or even severe or calcified nodal, we have to check the intravascular imaging, for example, IVUS and OCT to access the calcified segment. If the calcium arc is more than 270, maybe we need to use the special device, for example, rotablation or orbital atherectomy to prepare the lesion well before stenting. And finally, after stenting, we use IVUS and OCT to check the result, is it optimal or not. So the second slide is about the American approach for the lesion with a high calcium on coronary angiography. I think it's a little different from the zero intervention. First one, they do the balloon crossability. If the balloon cannot cross with the balloon, we try to use a microcatheter. And if the microcatheter can cross the lesion, we try to use a rotational atherectomy or orbital atherectomy. And after that, we use a balloon for optimal expansion before the stenting. And if the balloon cannot cross, if the microcatheter cannot cross the lesion, we have to use the direct wiring for the lesion. For example, the case of Professor Dũng, we use the rotor wire directly into the distal vessel of the LED. And after that, we try to use some special device to open the vessel. And if the lesion that balloon crossability is possible, we use a pre-dilatation with a small balloon. And after that, we check the IVUS OCT, and we see the calcium arc, is it over 180 degrees, or the calcium length is it longer than 5 mm, or the calcium thickness is over 0.5 mm. If yes, and this is the superficial calcification, we have to use the lithoplasty balloon. Is available in US, but it's not available in Vietnam. If this is the deep calcium, we can appreciate that the deep calcium is easy to dilate. So we use the balloon is enough for dilatation on the lesion. And we see the Asian Pacific Society of Interventional Cardiology, they have some, I think it's similar approach to the European society. With the angiographic calcification, we see a mild, we can do the balloon, just scoring balloon, a cutting balloon, NSC balloon is enough to dilate the lesion. And we see the intravascular imaging, for example, IVUS, I think is very important in the algorithm for the calcification like this. And we see it's similar to the Euro intervention. We have calcium arc, if it's over 270 degrees, we try to use some rotational atherectomy, something like that. So with 3 algorithms from European, from American, from Asian country, we see the important role of the intravascular imaging, especially for the IVUS, to deal with the calcified lesion. So with the IVUS, in the severely calcified lesion, we have to do 3 steps. The first one, we have to do the IVUS before the PCI. Before the PCI, we do the IVUS. We can see the severity of the calcium, and also we see the plaque characteristic, and we plan the PCI surgery for the patient. And also we see the potential complication during PCI with the IVUS finding. And during PCI with the IVUS for the calcified lesion, heavy calcified lesion, we can we know that the IVUS, the endpoint of the rotational atherectomy or the endpoint of the orbital atherectomy. And we also know that when we use the IVUS, we know that the lesion is prepared enough or not. And also we have the sensile selection for the lesion after we prepare the lesion. And finally, after stenting, we use IVUS to see the stent, is it optimized, optimal or not. And this is our experience. The pioneer of our experience is Professor Chung Quang Binh. In this section, we'll see the Professor Chung Quang Binh. We have some experience about the IVUS and rotaplator in our center. And in our center, IVUS penetration for the PCI is about 60% of PCI, and for the rota is almost 90% of rota. We try to use loss of IVUS in rotablation to reduce the complication, also to improve the stent optimization. And indication of the rota according to the IVUS in our center is that we have the moderately or severely calcified lesion over 180 degrees calcification of arch. And also we see, we heard about the indication from Dr. Wan Lee about the device could not rose, IVUS, a catheter could not rose, a balloon could not rose. That's a good point to try to do the rotablation. And also the cocktail in our center, we sometimes we don't have the rotaclide lubricant to do the rotablation. So we have the cocktail 5,000 heparin and 5 milligram NTG, and in the 500 saline. And guide for the rota, because in our center we only have the rotablation. We don't have the orbital. We don't have the lithotripsy. So the guiding for catheter for the rotablation, we use 7 French. On most of case 6 French or 7 French, but on most case with 7 French. And birth size we choose it's the birth to the artery ratio is about 0.5. 0.5 is mean that the vessel is about 3 mm. We choose the birth size is about 1.5 if we don't use IVUS in the rota. But if we use the IVUS and the cross the lesion easily, we measurement the IVUS by the IVUS minimal lumen diameter at the calcified lesion with plus 0.25 mm to choose the birth size for the rotablation. And in Vietnam, we have the birth size is about 125 to 2 mm for the calcified lesion. We choose that. And how to bring the bird to the platform, which you use a dynamic mode. And how about the speed in our center? We use with a small bird, we use high speed 180,000 to 200,000 RPM. And with a bigger bird, we use a speed about 160,000 RPM. And the endpoint of the rota with the IVUS, we see if we have the napkin ring, we can find out some crackles in the napkin ring. This is the endpoint of the rota with the calcium napkin ring. But with the calcium node or something like that, we have to see the lumen, is it big enough before stenting. And post rota, we usually use a cutting balloon or scoring balloon. We prefer scoring or cutting balloon than the NC balloon. And this is we can appreciate that this is the in vitro burr behavior with a lot with speed. We see that with a high speed, the burr is more stable, but with lower speed, we see here the burr is more unstable, and it touch into the vessel wall, into the wall more, and maybe that we make the damage more. It looks like the orbital atherectomy with the burr with a low speed. And for example, we have some case here. The first one, we have the patient with unstable angina. We see the CTO in the RCA. We have the collateral from the circumflex to the RCA, and we have the severe calcification in the mid LED, and we have some aneurysm in this. And you see here, this is the 7-friend guiding catheter, and we try to use an IVERS catheter, but IVERS, you see here, the IVERS catheter cannot cross the lesion. Yeah, you see here, the IVERS catheter cannot cross. So that's the point we have to try to do the rota. This is 1.5 because micro catheter cross a lesion. So we try to use the 1.5 burr first. You see here the calcified, heavily calcified lesion in the mid LED. And this is the IVERS post rota. You see here the Y bias. When we use the IVERS for the rotablation, or we orbital atherectomy, we see the Y bias. This is the Y bias. It touches into the vessel wall in this side, and you see that the IVERS slip into a more distal a little bit, and you see some vessel damage a little bit in 12 o'clock, because even this is not so calcified, but the IVERS catheter touch, the burr touch into this vessel. We have some vessel injury here. And we see the effectiveness of the rotablation. Yeah, and in this side, we see the calcified here, but the Y bias is not touched into the calcium, so we cannot see any reverberation in this calcium. So it means that in this side, the rotablation is not effective. And this here, we see the Y bias here. The Y bias touch the calcium here. So I think this side, we have some reverberation. It's small reverberation, but I think it's enough. Yeah, this is Y bias. I think it's good for rota, but this is a big vessel, very big vessel. So I think the 1.5 burr cannot touch the calcium. And this is the lesion size. You see that? Of course, I'm sorry. Yeah, in this view, you can see the IVERS. This is aneurysm in the in 9 to 10 o'clock, and you see the IVERS. Here we see the rotablation touch the calcium and make some reverberation in behind. So this is the effect of the rotablation by IVERS finding. I think it's a very good picture for the to see the IVERS, to see the rotablation effectiveness by the IVERS imaging. Yeah, you see here, and this is, you see here the reverberation in the 10 o'clock. It means that the rotable touch into this side of the vessel. Yeah, so we have some, oh, I'm sorry, it jumped. So after that, we use a balloon, drill balloon and see, and you see we can appreciate that in the distal, in the mid LED, we have some vessel injury because the rotable touch into the vessel. You know that even this is not calcified lesion, but sometimes the rotablation can make some injury in the vessel. And this is the final with the standing, the trio synergy stand, and yeah, and this is the left man. We see the standby lap position after standing, but after that we use a balloon, NC balloon, fall balloon, and make the stand in the left man full expanded into the vessel wall, into the left man. Yeah, you see that. Yeah, the stand now is full opposed to the vessel, to the left man. So before the PCI, we see that the LDD significant lesion and severe calcified and we have some aneurysm. But after that, the aneurysm, I think, is disappear a little bit, and we see the normal LAD right now. And the second case, we have the RCA. This patient came to the hospital because of unstable angina. In the left-hand side, you can appreciate that we have some haziness in the middle RCA here, and this is eccentric lesion. We don't know that this is the thrombosis or this is the calcification. So we check the IVUS. This is the IVUS. We see the some calcification from 9 o'clock to the 2 o'clock. This is superficial calcification. And we see more at the lesion. Yeah, we see here, this is the calcified nodule. This is calcified nodule, small calcified nodule is protruding into the vessel. Yeah, this is calcified nodule. And we see more the second calcified nodule come in. Yeah, you see the big calcified nodule here. We see here. Yeah, calcified nodule from the 9 o'clock to the 12 o'clock. You can see again. Yeah, you can see calcified nodule here. Yeah. So because this is the calcified nodule, we try to use the rotablation for this patient. This is the IVUS after the 2-hour rotablation with 160,000 RPM. This is the IVUS finding after rotablation. We try to use 4-time run of the rota 2.0. And in the right-hand side, you see that the rotablation touch into the calcified nodule. Yeah, you see in the both sides, and we make at the beginning it's flattened, but after the rotablation for the calcified nodule, we see the arch in the calcified nodule like this. And because we this lumen vessel is not big enough for standing, we try to make the bigger lumen by reduce the speed of the rotablation. So this is the 140,000 RPM. We reduce the speed of rotablation a little bit, and we can you can appreciate that in the left-hand side and right-hand side, the arch of the calcium at the calcified nodule now is bigger than the higher speed. Yeah, you can appreciate here. We see the bigger arch. It means that the rota effectiveness on the calcified nodule in the RCA. And you can see that at the beginning, before the rotablation, you see the calcified nodule in the RCA like this. But in the right-hand side, we can see that after the rotablation, we have the arch, the rotablation touch into the vessel wall. We have some reverberation beyond the calcified nodule, and the small arc of the calcified nodule here with the higher speed 160,000. And you see in the left hand side with the high speed 160,000, but when we reduce the speed 140,000, we make a bigger arc. I think in the right hand side, the RCA lumen diameter, I think, is big enough for stenting right now. At the beginning with the high speed, I think it's still small lumen diameter. And sometimes if the left hand side with high speed, if we don't make the good debulking for the calcified nodule, if we put the sand, sometimes we have sometimes we have the vessel rupture at the opposite side of the calcified nodule. So this is the case number 3. This is left main calcification. In the left hand side, you can see the left main bifurcation, and just in the distal left main by the angle, we see some haziness in the distal, and in the TME view, we see severe lesion in the distal left main, and also we have the significant lesion and also severe calcification from the left main to the proximal LAD. And this is IVERS finding for the left main LAD pullback. We see in the middle of the LAD, we see the eccentric plaque with the mixed plaque from fabric and also some fatty plaque here. In the proximal LAD, we have the moderate calcification, superficial calcification from the 9 o'clock to the 2 o'clock, but the lumen diameter is big enough. But in the distal left main, you see in the 1 o'clock, this circumflex Y, and this is the distal left main. We see the very this is heavily calcified lesion in the distal left main. You see that, and this is the circumflex pullback at 9 o'clock. We see the LAD Y. And we have opposite to the LD ostium, we have the severe calcification in the opposite sides of the LD ostium. This is the characteristic of the bifurcation, that sometimes we have the carina shift if we put the stent from the circumflex, if we choose the two stent technique. And because of heavily calcification in the left main distal, so we try to use the rotablation for this size. This is 1.75 burr for the both side LAD and also the circumflex. And this is the final. We final with the decay crust because this patient is quite stable. We do the decay crust for this patient. This is the final result of the patient. And the final case, and this is the case with left main disease, also the CTO in the RCA. We can appreciate that the left main disease diffuse to the circumflex, and the circumflex quite big here, and LAD diffuse lesion from the ostium to the middle LAD. And we also see the heavy calcification in the left coronary angiogram. And this is the RCA. RCA, we see the total occlusion CTO in the RCA. And for the safety reason, we try to do the PCI for the RCA first. And this is the final result of the RCA. Yeah, this is the RCA final. Yeah, I think it's good enough.
Yes.
Yeah, in the distal RCA, I think it's underfilled for the long time of the CTO, so we don't touch in the distal RCA. We just touch the middle from the proximal to the middle RCA. And after that, after 1 week later, we try to do the PCI for the left main disease. You know that heavy calcification in the right hand side, we cross the Y, but the IVERS catheter, you see that some very tricky resistance, and IVERS catheter cannot cross the heavy calcified lesion in the LAD. And because of IVERS could not cross the LAD lesion, we try to use the rotablation for the LAD. This is the first run for the LAD, but heavy calcification and the rotabler cannot cross the target lesion because this is a position of the IVERS tip cannot cross the lesion. So the target lesion should be here. And after many times of the rotablation, yeah, finally we cross the lesion in the LAD. And we run IVERS again because we avoid to damage the unnecessary rotablation position. So we try to IVERS again. You see that the IVERS catheter stuck here, still stuck in the middle of the LED. So we have to do the rotarun for the second time for the LED at the position that IVERS could not rotate the middle LED. Then after that, we learn about the bifurcation, that when we have the severe calcification in the bifurcation, normally we have to do the rotablation for the both sides, both branch of the bifurcation for the optimal results. So this is the rotablation for circumflex. At the beginning, if the rotablation cannot cross on the middle of circumflex here, but finally it cross a lesion here. So this is the beginning of the procedure. We have the diffuse lesion from the left main to the LED and also the circumflex. But this is the final lesion, final result of the PCI on this patient. Of course, this patient refused carpet surgery. So for conclusion, I think the IVERS is a very important device in PCI for heavily calcified coronary lesions. And IVERS help us to determine the strategy for heavily calcified patient, also to prevent the complication during the PCI by check the IVERS. While by us also we can check the plaque characteristic before we do the procedure. And also the IVERS help us to optimize stenting results. So that's in my presentation. Thank you very much for your attention.
Yes. What?
Well, I think this time of the Gautam Kumar, you can control the discussion.
Yes, that was a very complicated case that you showed. Now, actually, not just a complicated case, complicated 4 cases. And I think that was extremely difficult and great demonstration. Now, I had a question for you. Now, in terms of doing low speed rotational atherectomy, what is the lowest speed that you have gone to?
For the bigger bird, the lowest is 140,000. 140,000, the lowest one. Okay. Yeah, because we at the beginning we try to do the rotablation with a higher speed when we want to cross the lesion with the rotabird. But after we cross the lesion, we usually will reduce the speed a little bit to get the big debulking, to prepare the lesion. So in the same case, at the beginning, we usually get a higher speed, maybe 180,000 or 200,000 to cross the lesion first, and after that we reduce the pace. And the lowest one is 140,000. Yeah.
Excellent.
I would like to ask one question.
Yes.
Yes. Because in the second case, the complex case, the second case, you see it's the angle, it is the CVS classification in the mid LED, and the toxicity, very toxicity about 70 on 70, 80 degree, it's the angle. So when we use the rotor wide, it's a bias on the I want you see that very, very clearly. Why? You choose the big rotable 1.5 millimeter for the rotablation, because it's easy to make the perforation or perforation in this case like this, and as you when some experience when the wide bias like this. Yes, thank you. because when we use the rotabulation in the bias, why bias, we must use the small burr, rotabur, 1.25. First, after that, you 1.5. Yes.
Because in this case, when we check the IVUS at the beginning, you see here
LED, not the
LED. The first
LED,
case
the
or
big
second
LED.
case?
Second case.
This is the second case.
Yes, second
maybe
case.
The third case.
Maybe third case. I'm not sure.
Yeah, this is third case. Yeah, you see that by the IVUS, you see here by the IVUS finding, we can choose the burr size for by the IVUS finding. And this is measurement. We see here the minimal lumen diameter at the calcium plaque here is about 1.5 because we know that IVUS catheter is about 1 mm. I think this is about 1.5 or 1.6 mm. So normally we measure this diameter and we plus 0.25 mm and we that the burr size diameter for the rotablation. In this case, we choose 175 at the beginning burr for this case. And sometimes this case we can try the 2.0 burr, but in Vietnam 2.0 burr is very rarely, so we cannot find the 2.0 burr in Vietnam. Only 175. So this is the IVUS guidance to choose the burr size when we do the rotational atherectomy. In this case, you see that IVUS catheter on 1 mm. I think this is 1.5, 1.6 mm, and we choose a 175. I think is enough for this case.
Yeah. Okay. I saw one question from the audience, comment from audience, Dr. Hong, Dr. Ngô Minh Hồng from the General Hospital to ask the panelists that in Protect 1, Protect 2 trial, the result it failed to use mechanical circulatory support. Why? In this case, in some case, severe case, we can give a still use the mechanical device support. Yes, you see the question from the audience. Dr. Ngô Minh Hồng, yes, can you share the experience and some experience in this case like this? Yes.
Yeah, I answered that question on the Q&A. So basically in Protect 2, just to remind everybody, that was a randomized trial in high-risk PCI of patients to both IBP versus Impella 2.5 specifically. The trial was statistically equivalent at 30 days, but at 90 days, there was a favor towards Impella 2.5 direction. I think it was like 50% versus 40% or something in outcomes. So it was a close trial. It is possible to do IBP. I think the Protect 2 inclusion criteria was too large, and sometimes they just did low EF patients. I think for us, really, we find that we tend to only use the Impella as support when you get to the extreme side of the inclusion criteria for Protect 2. So I will tend to not use it unless I have multiple criteria for Protect 2 present in the same patient. Like they have low EF, they have last remaining vessel, just like the case that was shared earlier. And it's also important to remember that the current Impella is the Impella CP, which can get up to 3.5, and sometimes even 4 liters a minute in patients versus what they use in the 2.5. And there is no question for us that in high-risk patients who are unstable, the Impella patients are definitely more stable than the IABP patients. So whatever the trial data shows, it's definitely better. And now we do a lot of TAVR here. We use a lot of large bore access. So our experience with managing large bore 14 French sheaths is a lot better. And so our hemostasis and bleeding risk is much lower than it used to be before. And nowadays, when we use impeller CP as well, we use single access technique, where we put the guide through the impeller sheath as well for the PCI. So there's only one access, which also tends to help things. So, those are the things that have happened since the Protect 2 trial. And this is why we still like impeller. Dr. Kumar, do you have anything to add to that? Or?
No, actually, there's been a lot of advances, as you have described, with the impeller. We've become more facile with large sheets, especially with our structural heart program. There is an ongoing Protect 4 study at this point in time that may shed some light into complex PCI as to whether the impeller support may be helpful or not. But that is an ongoing trial. I think we are running about 20 minutes behind. So in the interest of time, if it is okay with the panel, I will also go ahead and introduce the next speaker. The next speaker is actually my colleague and a very good friend, Dr. Rajesh Sachdev, who is actually my colleague at the Atlanta VA Medical Center. He's a professor of medicine here, and he has been a great partner and friend for me for several years, and has extensive publications in complex PCI, FFR, coronary artery disease, and it is a great pleasure for me to introduce him, Dr. Sachdev. You may be on mute because we cannot hear you yet. There you are.
Okay. Can you hear me?
Yes.
Good. Good morning, and thank you for a great introduction, Gautam. I thank the organizing committee for Vietnamese, the Society for Interventional Cardiology, Dr. Wen, Dr. Lee, for this opportunity to present in such a prestigious forum. I think I started with. Okay. I'm going to present about shock waves through the heart, the role of IVL in calcified coronary artery disease. So far, it has been a great presentations. Some of the material which I'm going to present, those slides may be a duplicate. Some of the previous speakers have already touched upon this part. So the fibrocalcific disease is mostly seen in stable coronary artery disease.
I am sorry. I'm sorry. Look like your presentation not full in screen. The technician.
We are only seeing half the screen.
Yeah.
The left half of the screen is what we are seeing. So maybe you can
share again. Share screen again.
Reshare. Yeah.
You might be sharing on a second screen if you.
Okay. Beautiful.
Yeah.
Beautiful. Yeah.
So let me go to this again. Are you able to see the
again?
No, it's half the screen again.
Okay. All right, no worries.
Maybe you can just run it from this screen. Yes, just run it from here.
It's okay.
Okay. I can. There's a possibility the movies may not play. Okay. All right. So there are two different types of calcification. One is the intimal. The other one is a medial calcification. Intimal calcification mainly involves the coronary arteries, and the medial calcification usually involves the larger vessels, especially aorta and peripheral vessels, and is seen in patients with end-stage renal disease. As far as intimal calcification is concerned, the oxidative stress leads to inflammation, and the smooth muscle cells turns into osteoblast cells and leads to deposition of calcium. There is also macrophages, which are supposed to play as osteoclast cells, and there is a downregulation of that, leading to further calcification. we all know that PCI of heavily calcified lesion is associated with procedural complications and or related adverse events. When a balloon is inflated in a calcified lesion, and there is a possibility of dissection or perforation, especially when you go on high pressures. For the calcified lesion impedes the stent delivery. And even if you're able to deliver the stent, there is a possibility that stent may not expand, which can further result in increase in ischemic events. So the limitations with the balloon-based therapies are that high pressure balloons preferentially expand away from the calcium, having limited effect on eccentric calcium. High pressure inflations are predisposed to major dissection and perforation, often at the interface between the calcium and healthy tissue. And balloons are typically unable to modify deep or thick calcium. So what are the modalities which are available in today's era? Atherectomy is the main sort of stay, which includes rotational atherectomy, and we heard a lot about it. Along with that is orbital atherectomy. Now, these techniques or the therapies require dedicated wires. There is thermal injury, which promotes platelet activation, leading to increased risk of clotting, which can result in distal embolization, resulting in slow flow or no reflow, which can result in periprocedural myocardial infarction. And ablation is contact dependent. It's unable to modify calcium in a larger lumens and a deeper calcium. It's unable to protect the side branch with a second guide wire. Now, the potential is also there to transect the wire and lead to large dissections and perforation, especially in atrocious anatomy. Now, lithotripsy has been available in the extracorporeal lithotripsy in kidneys for past 3 decades. We have used this lithotripsy techniques for breaking up the kidney stones. The intravascular lithotripsy is a miniature and arrayed lithotripsy emitters for localized lithotripsy of the intravascular or the coronary arteries. The difference between the extracorporeal lithotripsy versus the intravascular lithotripsy is that the energy profile is really low, as shown in the graph. The energy which is sort of produced in terms of pressure, measured in pressure, is about almost 100 atmospheres, and the energy or the pressure which is produced in the intravascular lithotripsy is somewhere around 50 atmospheres. So what are the potential opportunities for coronary intravascular lithotripsy? There is no requirement for a specialized wire. Shock waves pass through the plaque and vessel walls, enabling modification of the deep calcium, and disrupted calcium remains in the vessel wall, thereby reducing the risk of distal embolization. Now, lithotripsy allows calcium modification to be performed at low balloon pressures, thereby avoiding the risk associated with high pressure inflations. It also enables one to protect the side branch with a second guide wire. The components of IV include a generator, a connector cable, a catheter, which has a balloon. A balloon is about 12 millimeters, and it has 2 emitters, and the balloon sizes are 2.5 to 4 millimeters, and it is capable to give 80 impulses. So the mechanism of shock wave is various ways it works through. As I said, there is an initial rise in pressure, which is in 1 microsecond. The pressure goes up to 50 atmospheres. That is called the shock wave. And then in next couple of microseconds, there is a negative pressure, which is also called the tensile phase. So the shock wave causes a squeezing, which can result in the circumferential force on the calcium, leading to tensile and shear stress at the proximal and the distal ends, leading to fracturing. The second force, which acts as a cavitation force, which is at the surface of the calcium, and this starts when there is a sort of a negative pressure and the negative jets are created, and that also leads to fracturing. The calcium which is there in the arteries has imperfections, so all these forces, when they're acting, they causes fractures by like fatigue fractures or stress fractures. And lastly, the shear stress which is there is called the suppletion force. While the calcium is moving in one direction, the energy is reflected from the distal or the farther part of calcium, and then the more proximal part starts moving in the other direction, while the distal part is still moving in the same direction, which creates more fractures. So this is a video which shows how this IVL works in situ.
The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. When the waves impact the calcium at nearly 50 atmospheres, the vessel becomes more compliant.
So this electric energy is delivered to the emitter, initiating a steam bubble which expands and collapses, creating a sonic pressure wave. And this sort of a pressure wave then impacts the vessel wall and the calcium in the vessel wall at the balloon vessel interface. This is the video which shows that the calcium-like material is on top of the balloon, and when the IVL is initiated, how a harder calcium-like material can be broken into small particles and break apart. On the other hand, the softer tissue on the right-hand side, the energy is able to dissipate through the softer tissue, resulting in no damage to the tissue. This is the OCT showing a 360-degree calcium and a OCT after the IVL treatment, leading to both longitudinal as well as circumferential cracks. And this sort of can result in optimal expansion when the stent is deployed. Now, this is a pre-IVL picture of calcium and a micro OCT showing that when a IVL is applied to this calcium, can result in microfractures, which could be longitudinal or circumferential. And this is on the right-hand side is a histological picture of a microfracture shown over here and here, and same microfracture is on a micro CT. So there have been several studies showing the efficacy of IVL. The first study was a Disrupt CAD-1 study. It was a safety and feasibility trial. Second was a Disrupt CAD-2 study, which was a safety and effectiveness trial. And then the third study was a Disrupt CAD-3 study, which led to the approval of IVL in US. And I will be talking a little more detail about this particular study. So what all these studies have shown is consistent procedural success and a low MACE rate. So talking in a particular CAD-3 study, majority of these patients had class 2 and class 3 angina. There were some patients with even asymptomatic ischemia which were enrolled. all sorts of vessels were involved. The calcified length was about 48 millimeters, and all these patients have severe calcium. The total procedure time was about 53 minutes, and there were about 1.2 catheters used on an average, and the stent was delivered in 99% of the patients. The procedure was successful in terms of device crossing in 96% of the patients, and procedure success was in about 92% of the patients, with minimal complications post-IVL, mainly because of dissection, which were tacked up with the stents. So when you look at the MACE rate, the MACE rate was about 7% in hospital and about 8% at 30 days, and mostly it's driven by myocardial infarction, which is as a result of peri-procedure myocardial infarction mainly. So there was another arm in this trial, which was the OCT arm, where they enrolled about 100 patients. They had undergone a pre-procedure OCT, a OCT after the IVL, and a OCT after the stent. And the findings were quite interesting. As you can see, the maximum calcium angle was 293, and the maximum calcium thickness was about 1 millimeter. And after the IVL treatment and stent placement, the minimal stent area achieved was 6.5 millimeters square, which is pretty good. So the conclusion of this study was the DISRUPT CID3 trial achieved both primary safety and effectiveness endpoints, and coronary IVL prior to DS was well tolerated with a low rate of major peri-procedural complications, and OCT demonstrated longitudinal circumfracture calcium fractures, leading to increased vessel compliance and large post-procedure MSA with excellent stent expansion. This is a case from our cath lab. This is a patient with coronary artery disease who presented with angina, has a moderate disease in the mid-LAD. He underwent FFR assessment. The RFR was 0.83, and the FFR was 0.78. The IVUS did not cross the stenosis. He underwent aorta ablation. After the aorta ablation, IVUS was again attempted. It was again a no cross, but you can see there is at least a 180-degree calcium, which is there. So an IVL balloon was used, a 2.5 by 12 millimeter IVL balloon was used, and I think about 50 impulses was given. And after that, you can see that this leads to fractures over here at 12 o'clock position, and you can see as it moves forward, there is a fracture even at 3 o'clock position right here. This was followed by a placement of a balloon, a chopped up balloon, and followed by a stent, and with the good expansion and apposition. IVL has been used in multiple other lesions besides what have been studied, including left main, large vessels, bifurcation lesions, ostial and tortuous lesions. So that brings us to a question. What are the patients where you need to use OCT? And some of this has been addressed in previous talks by Dr. Lee and Dr. Kumar, and I will go to the algorithm and I will just walk you through this algorithm. The best candidate which can be benefited from IVL is a patient who has angiographic assessment and shows that there is calcium. Now, if this patient you cannot cross, it doesn't make to put a IVL balloon there, so you won't go to rotational atherectomy or laser or orbital atherectomy. But if you're able to do a imaging, OCT is preferred, but you can use the IVUS, and on OCT or IVUS, you're looking at the arc of the calcium. If arc of the calcium is less than 180, you can use the specialty balloons to actually dilate this, and after pre-dilatation or adequate pre-dilatation, you can do the stenting. Now, if there is nodal calcium, the preferred way to treat this is rotational atherectomy, as shown by one of the previous presenters. Now, if this is a greater than 180-degree calcium, you want to further assess the thickness of the calcium. If the calcium is thicker than 0.5 millimeter, IVL is the better modality to treat this kind of a calcified lesion. Now, if the calcium is less than 0.5 millimeter, I think you want to look at the length of the calcium. If it's greater than 5 millimeter, they will benefit from IVL treatment. We also believe that these patients can be treated in a different way, especially the ones where you are unable to really cross the stenosis. I talked about the primary IVL treatment, which was studied in Disrupt CAD3 trial, but there is a subgroup of patients where you're not able to cross with a balloon or a imaging catheter. And I think this so-called secondary or rota-shock treatment could be beneficial. This could be applied as a rescue treatment if there is an inability to dilate the vessel with a conventional balloon or rotational atherectomy. You can apply a shock wave to that, or it can be used as a more of an elective that you can actually do a rotational atherectomy with a small burr like 1.5 burr and followed by IVL, and that will give you a radial access to the smaller sheath size with the potential decrease in embolization. Thank you.
Xin mời Dr. Nghĩa, your moderator.
Yeah, thank you. I would like to ask you one question, Doctor. Because I had one case, a patient is 75-year-old. 10 years ago, 5 years ago, when we do angiogram, the patient had the mid-LD severe with severe calcification in the mid-LD. So I do the angiogram, we do the rotaplator with 1.5. 1.5. After that, we use we deploy the stent 3.5, 20. But after the 3.5, 20, we use the NC balloon. I go up to the 20 millimeter atmosphere. We cannot open, not fully expansion. I go to 24. So, after that, the patient discharged from my hospital. And 2 years later, the patient come back with the chest span. I do angiogram again. We see the restenosis in the mid-LD. I only because we already deployed stent already, so we only did the NC balloon to reopen only. But now the weight in the mid stent is still have. So now this case we can use the lithotripsy. It's difficult for me to treat the patient. I will ask you a question, and this patient can use the IVL or not? It is the best option for the patient or not? Thank you.
So I'll give you an example. Recently, when IVL was approved, we had a patient that had come with angina, is unstable angina, had known coronary artery disease with multiple layers of stent in the right coronary artery. And there was a focal instant restenosis. And we thought we could just balloon it and dilate it. And we ballooned it. It looked like the balloon was expanded. It was more like a napkin ring kind of a stenosis. Believe me, the FFR was positive. It was a napkin ring kind of stenosis. We balloon looks expanded, and I placed a stent. And when I placed the stent did not expand it completely in the middle. And you know, I used a NC balloon, tried to post dilate, went to 30 atmospheres, it won't yield. So at that time, IVL was approved for periphery. It was not approved for coronary. So we actually had him come back, and we used the peripheral IVL, a 4O balloon in that patient. And you know, with the 20 treatments, that area was opened up. And we used the high pressure NC balloon, and that artery looked beautiful after that. So I think there is a utility of this technology. And on the other hand, yes, there are other modalities also, like laser you could have used, but laser is not available in each and every hospital. There is a very limited penetration of laser. But I think IVL has much more promise. I think down the road, as it is utilized more and there is more and more trials, and there is a comparison of IVL with other sort of technologies like atherectomy, rota or Whittle, I think there is going to be a lot more sort of usage of IVL. I think it's going to show that it has a promising career down the road.
Yeah, thank you. Thank you. Thank you.
So, Dr. Nghĩa, I think in your case, we have a restenosis, instant restenosis. That time, maybe we use IVAT to know the mechanism of the restenosis. We have the hyperplasia of the intimal, or we have a new atherosclerosis at the inside the stent. And when we know the mechanism, we can choose the way to treat your patient.
Thank you.
Yes, and it has been very well reported that the hyperplasia or neuroatherosclerosis, which happens inside the stent, can be calcified, and it has been already published that you can develop a 360-degree calcium in this hyperplastic tissue.
Yeah, thank you. Thank you. At that time, the patient with intense restenosis, the IVUS machine in my cath lab is this out of order, so I cannot record it inside the stand inside. But when I go up the NC balloon 24 atmosphere, the wet is persistent, still persistent, not disappear. So I think napkin ring in this patient is very thick, and I think I'm not sure. Yes. I would like to ask the doctor one question about IVN. It is better for the luminal, superficial, or median calcification or not? Is the benefits in the superficial calcification or the media calcification? Yes.
In both.
In both.
In both.
In both.
Yeah. So in the periphery, it is used, and usually the calcification of peripheral arteries is a medial calcification when you're dealing with iliacs, and there is a combination, I should say, both intimal as well as medial calcification. And IVL is the treatment actually works on both.
Yeah, thank you.
Dr. Nghĩa, Dr. Đinh Đức Huy, right hand.
Right hand, yeah, okay.
Sorry, there was a very good question in the Q&A. Somebody asked the question, when you have immediate under expansion of a DES, can you use an IVL immediately? Will it cause the polymer to damage? And does that cause your DES to be less effective? The company has some data that shows that the polymer is damaged by the IVL. So some people would recommend that you bring them back. But obviously, if the stent regret is very severe, you may be taking a risk by not fixing it straight away. So sometimes we have done it straight away before. We did some experiments at the University of Arizona where we did in vitro expansion of both the Zions and the Resolute. And then we subjected the stents to 80 pulses. And then we studied them under an electron microscope. And there was no polymer damage, contrary to what the company said. So maybe it's okay. The other way to fix the problem, if you are worried about it, obviously, if you have a drug-coated balloon, you use a drug-coated balloon after you have done that to the stent, or you can put another new drug-eluting stent inside the first drug-eluting stent. Nobody knows for sure, and it's never been studied formally before.
Yeah.
Sorry.
And
Dr. Hui. That was a fantastic question, and thank you for answering that. Dr. Lee. In our case, we actually waited for about 3 weeks. So majority of the drug is eluted before we actually brought this patient back for the same reason.
Dr. Rajesh, can I ask, is there any factors, angiographic or imaging, that can predict successful or failure of IVL procedure?
Not angiographic per se. You want to see fractures with the IVUS, and one thing you can see is the IVUS crosses through initially if you're not able to cross, that you have made some made some fractures, that's why you're able to cross. On the other hand, now if there is a dog boning in the balloon catheter, when you inflate it angiographically, when you're giving impulses and that dog boning goes away angiographically, then you can say that you have treated that lesion. Now, there is a good possibility majority of the lesions you're doing, you may not see the dog boning. In a particular case where you're seeing that one particular area is not dilated and you start giving impulses because you're applying only 4 atmospheric pressure and that balloon opens up, you know that you have successfully treated that area. On the contrary, if the balloon was sort of expanded and you applied those impulses, you probably won't be able to say angiographically that you have actually adequately treated that lesion or caused some fractures in that. So you have to study with either IVUS or OCT.
Yes, okay, thank you. Now I think I need to move on the last presentation. Dr. Dũng. Yes, and then the next, and now we move on to the next presentation is the from the Dr. Nguyễn Bằng Tân from the Thống Nhất Zero Hospital. he present. He very experienced in the interventional cardiologist. Now he present the OCT guided treatment of calcified coronary artery disease. Please, Dr. Tang, please.
Thank you for your introduction very much. Can you see here? Can you see my sharing slide?
Yes, very clear. Yes.
So, the chest pain and panelists, I'm very happy to see my colleagues in Vietnam and the US again online today. So my sharing today will be about OCT guide treatment of calcified coronary artery disease. As we all know, OCT imaging play a very good and useful role in the field BCI, and OCT can help us identify characteristics and image of a coronary lesion, help optimize the size of stent before and after intervention. You can see the lateral image with coronary angiography along, and when OCT was done, we see very clear the characteristics of the lesion in the rock section or the longitudinal view compared to angiography alone. Up to now, we have known that imaging play a very important role in the BCI and the IVUS. It's also very useful in imaging modality, as Dr. Kumar and Dr. Wally mentioned before. So OCT seems to be more dominant than IVUS in the detection, identification, and qualification of the calcified lesion. The role of the OCT is better than the DAS angiography alone, CT scan, or IVUS. When we apply the OCT equilibrium intervention, for simplicity, we can remember term MLD before stenting and MAX mark after stenting, step-by-step OCT workflow to guide treatment decision-free and block BCI. With MLD can help us identify the characteristic lesion, morphology, length, diameter. And both BCI OCT, you can measure the dissection, position, and expansion. Up to now, there are also quite a few studies evaluating the role of OCT guide intervention compared with angiography alone, such as Illumin, 1 or 3, and Doctor and Ben London. So the result of these studies suggest that OCT intervention improve procedure success in hospital event and long-term mortality when compared with the BCI-based angiography alone. In this study, conducted in the United States more than 2,000 live lab procedure in 2019 and 2020 with more than 300 patient BCI based on OCT guide BCI, and with you see here more than 650 lesions for evaluate. So now we apply to the MLD MAC model. We can see a process 30% patient receive elective BCI and 60% receive BCI in the failure approach, and 55% have T or coronary lesion. Results so that's OCT chain angiography based decision in 98% lesion. OCT help to make decision chain free and block BCIs. Most prominently is especially as lesion assessment, lesion tab, stent length, stent diameter, and expansion. Evaluation of coronary lesion by OCT have to change the treatment decision on more lesion when compared with angiography alone. And it accurate diagnosis of calcium, severity, fry chain in the vessel reversal trajectory in not calcified lesion, the EU, OCT, free and BCI chain 47% of intervention device, as well as 27% of the vascular reversal method of BCI. Pre-BCI angiography assessment and plan treatment approach was changed after performing free BCI OCT. Let me give an example, like in the ones above, as we see that's based on angiography alone, we would characterize this lesion in the mid LAD, and would blend the BCI trajectory. You look at in the MLD, the morphology and the length about 30 mm, and diameter about 30 distal, and about 3.0 in the distal and the 3.5 in the proximal. So after you use the OCT, we change the morphology about the calcified mid-LAD lesion, and the length of the lesion more than 38 mm, and diameter in the distal and 2.S and in the proximal 2.75. So after that, we change the trajectory for stenting. The summary and ongoing pivotal OCT study suggest aluminum 4, Aclip, and Renovas have a relatively large number of patients, and the RCT in the basin, while high risk severe calcification and front of the OCT, BCI compared with angiography alone. We expect early result of these RCTs with express bone and cardiovascular event according between two groups. Calcium is associated with the degree procedure success and stent and expansion, result in the advanced clinical outcome from the left to right. Superficial, you see, superficial almost 360 degree calcium nodule around in the 9 o'clock and very deep field calcium, and from the eye clock superficial degree 360 degree concentric calcium data fracture in the 3 o'clock and the 6 o'clock and 9 o'clock. So now we can have the OCT classification of calcium. You look at the first is the superficial calcium and the deep calcium and the nodular calcium and the eccentric calcium and the concentric calcium very clearly when we see in the OCT. And based on the OCT calcium, we have the OCT calcium score as Dr. Kwan Lee and Dr. Kumar mentioned before. We have the rule of 5. The first, we have the maximum calcium angle, the maximum calcium thickness, and the calcium length. We have total score about 4 boys, and the lesion at the rate of the stent at the Benson have a calcium score of 4. And to summarize the reverse presentation, I would like to present flowchart and describe how to diagnose and treat calcium lesion with OCT by Evan Scormith in the USA. In 2019, I think the flowchart to approach the treatment of calcium lesion is quite simple and easy to apply in practice daily. This diagram shows us when the calcium was identified by OCT, we divide into 3 types: SO deep calcium, superficial calcium, and nodular calcium. And then we can choose the divide for deep calcium. We can choose NC balloon, core balloon, or cutting balloon, and the superficial calcium. We can choose we can choose balloons drossable, undrossable. You can lithotripsy, and another one we can use rotaplator, and then we stent in. So in this session, I would like to present 2 clinical cases in the our cat lab. The first case I want to talk male, 62 years old, present with unstopped angina, and the patient have history of the non-STEMI with TVD. Stented LDE RCA circumcised 4 years ago with risk factor, hypertension, DLVs, and smoking. In angiography, you look at here, the steady RCA is normal. So in the left side, especially the LAD, we can more moderate stent restenosis in the mid LAD. So very deep field lesion in the proximal to the mid and before the stent in the LAD here. So when I use OCT to check the lesion from the distal, middle distal LED to proximal, we can see stent restenosis, very severe stent restenosis. And in the proximal, heavy calcified, you look at around here. And to measure in the image after measure in the OCT, in the distal, in the stent, we have very severe neoplasia here, and the proxy in the mid and in proximal. After we measure by the OCT, and the calcified mid LED lesion in the moderate with deep calcium. So we approach by algorithm. That's we use LC balloon 2.75 when we measure in the diameter of the lesion. So after use LC balloon, we use boost the two stenting and the proximal to the distal to the proximal, and LC balloon more beat again more than 3. This is the 5 renal angiography. So look at the very good, and we look at the OCT here after stenting. It's very clear, and the stent very good without male apposition. In the second case, in the male, 69 years old, recent with non-STEMI, risk factor, hypertension, diabetes, and frailty with moderate level. So we look at the picture. In the RCI is normal, but in the left side, very high sinus in the proximal and heavy calcified by angiography, very severe in the proximal. So when we use the OCT from the mid to the proximal, we can find very heavy calcified in the proximal, and you look at the picture around here, very heavy calcified here, and very severe in proximal. When I measure the distal in the mid and the proximal, we heavy calcified, and measure the information from the proximal to the distal assessment with stenting, with support by the protablator. We want to debunk heavy calcified here, and because of OCT calcified score of 4 point, so we measure the length and the diameter of the vessel, and then we boost to stent from the mid to the proximal, depend on the OCT guided. After stenting, it's a very good angiography in the LED and left main. So we look at in the OCT stent acquisition very good. In conclusion here, I want to have some message. The management of the calcific obstruction coronary disease remain a problem, and coronary artery calcification often appreciated by angiography alone. So OCT permit recognize of the calcified block with accurate anatomy and morphology characteristics. And when we have OCT information, we can repair the lesion very good before stenting. And on OCT-based algorithm, approach to diagnosis and treatment of the calcified blocks in on patient treated with PCI. Thank you for your listening.
Yeah, thank you. Thank you.
Thank you, Dr. Tan, for sharing the lectures about OCT, guided PCI, and the role of OCT in identify of calcified lesions. So I think we still have time for discussion. So we want to hear from panelists. Maybe we start with Kwan. you do a lot of OCT guide PCI. So can you have a comment for the lecture of Tan?
Yeah, no, I thought that was a very nice summary, and with two very nice cases demonstrating how well the OCT could show, the depth of the calcium, and also I think with the with the longitudinal view, because the longitudinal pullback on OCT is so much more consistent and so much more accurate compared to longitudinal IVUS pullback. It's very clear where exactly the points are, especially if you have the capability of OCT co-registration with angiography. And the new Ultron software that's coming out also has a lot of artificial intelligence analysis built into it, which will allow the machine to or the software to automatically tell you exactly where you need to consider plaque modification therapy. But that's probably not available in Vietnam yet. It just is about to come out here. There's no improvement to the actual imaging in the engine itself, but the software for analysis is much better. So I thought just very nice demonstration of how to use the OCT. The one thing I would say is that I went back and forth. I did a lot of IVUS in the beginning, and then I did a lot of OCT. And I have to admit, I'm slowly going back towards IVUS because I find that with IVUS, I tend to increase my stent size. When I use the IVUS to optimize, my stent size is larger on IVUS than OCT because you can see the EVM. So, but definitely, I think you can't be dogmatic and just go one versus the other. You have to choose the right patient in which the right imaging modality is the better imaging modality for your patient. And both have their strengths for sure.
Thank you, Dr. Conley. So Dr. Tan, can I ask, for elderly patients with ACS, so normally we see three vessel disease and very calcified lesions. So then OCT, can you use this kind of technique to identify which ones is complete lesions?
Yeah, thank you for your question. Usually you can do without a clot in the lumen of the coronary. If without clot, you can do this. And the TIMI flow, I think TIMI flow 3, you can do this. Yes. So the line.
Just to make a point about OCT and IVUS, I think OCT gives you a very good quality image, and usually a good quality image leads to good decisions. IVUS at times can give you a poor quality, and you may not be able to decide. But on the other hand, you have to also see risk versus benefit. In a patient who has kidney disease, has creatinine 2, and you need to do a imaging modality, you can't just say that I'm going to take a good quality image and use 20 cc of contrast just to acquire an image. And I may need to use another image to optimize or see how I actually performed. So you're actually risking renal injury in that particular patient. So you got to weigh your risk versus benefit and use modality to help you rather than sticking that one is better than the other. I think they both complement each other with the different patient population.
Thank you, Dr. Rajesh, for commenting about how to select an imaging device during PCI procedure. So I think it's now time to go to the last presentations by Dr. Nguyen. So he's now the chief of Department of Interventional Cardiology at Jorai Hospital, one of the biggest center of disease in Vietnam. So Dr. Nghĩa, please.
Yes. Yes. Good afternoon, everybody. I'm very honored to present. This is the last presentation. I'm very honored to present the some experience in the applied atherectomy and the casting and scoring balloon technique at my hospital. Yes. Yet as you know, the coronary artery disease is the leading cause of the case and morbidity in developed and developing work. Now in Vietnam, the same. Yeah. And complex coronary artery disease are common in clinical practice. It's in the, according to some research, some trial research, global leader, diabetes, everything. It's about 30 complex coronary artery disease account for 30% about. For the specifics, the coronary anatomic feature are commonly considered to be marker interventional procedural complexity. The presence of the calcium, the second, the severe toxicity, 3, and high thrombus content, 4, diffuse atherosclerosis burden. Of these features, the lesion was very severe calcified lesion are probably the most challenging. According to the MACCAP, about in 2000, in the complexity, the calcified lesion is very challenging. Yes. The prevalence of calcification is age and sex dependent, more common in the men older than 70. Its account, moderate and severe calcification can be encountered in up to 1/3 of the coronary lesion. Yes. After the calcified lesion is affected by the clinical outcome. According to Purantas in the pool meta-analysis in 7 stand trial about more than 6,000 patients, and you see if the patient compare without severe calcification appear to have independent predicted prognosis when PCI. You see it's the MI and the death in the patient with the calcified severe calcified calcification. It did without. You see the same. In the severe lesion calcification were less likely to have a complete revascularization. In the pool meta-analysis, it is 48% compared with 55%, and mortality is very high in the calcified lesion. So this is the challenging when we do the when we must diagnose the calcification when we do the angiogram. A lot of the modality for the defined calcification, especially for the arc of the calcification. Yeah. You see, it is we usually the IVUS angiography and the OCT. You see, in the IVUS and OCT, very useful for the calcification. Angiography only 38%. There's moderate and severe calcification when we do angiogram, according to the pivotal trial from the Garimin. Yes. So it's the timeline for the development of management of rigid calcified coronary lesion, because we had two times. One, atherectomy. It's the ablation device. We usually use the rotablator, orbital atherectomy, and lithotripsy, IVL, or the excimer laser. The atherotomy, only the chain modify the atheros plug only. It's the usually balloon based device. It's the timeline. The first in 1998 after PCI into the system, we use the balloon. After that, when we see when we encounter the rigid rigid lesion, we use the NC semi-compliant balloon and NC balloon. After that, in 1998, we use the rotablation with rotablator. In 1991, we use the score acoustic balloon. But recently, we use the chocolate balloon. In 2008, another atherectomy device is the orbital atherectomy. But recently, we IBN and eczema lesion in 2009. It's the timeline for development in management of rigid calcified lesion. The first is the role of the plaque modified device. In the IVUS, you see the soft fatty lesion, the fibrocalcified lesion, and severe calcified lesion. In the soft fatty lesion, we can use BOBA or stent. And the fibrotic calcified lesion, usually moderate, we can use the score balloon, skirted balloon, score balloon, and the skirted balloon. Avoid the slippage, avoid the plaque shape. So easy for the moderate and mild calcified lesion, or ostium lesion, and instant restenosis. And severe calcified lesion, especially for the if the calcification over 270 degrees, we must use the atherectomy device, especially the rotational atherectomy or orbital atherectomy. Yes. Yeah. First, I talk about the atherectomy. Atherectomy is consists of rotablation or orbital atherectomy. Make the plaque modifying, facilitate stent implantation in undilatable, rigid, heavily calcified lesion. Rotablation ablation is a catheter with the nickel placed brass nozzle with the surface about 200 to 2,500 microparticle with a diameter about 20 millimeter. When operation can rotate at speed from 100,000, 150,000 to 200,000 rounds per minute. It's true and make erosion severe and make the about 10 to 20 microparticle. But when we use the orbital, recently in 2008, orbital atherectomy enter in the investigation with the principal elliptical burr movement. The OA device use eccentric mounted diamond coated crown that orbits at the over an atherectomy wide at speed about 80 and to 120,000 rounds per minute. So it makes a very small microparticle about 2 millimeter. Compare with the BOBA, the rotablation atherectomy or orbital atherectomy, modify the plaque composition, but the many clinical trials so that it not change the prognosis after the rotablation. Yeah, you see it's like a mechanism of a rotational atherectomy because centrifugal erosion or spirality. Atherectomy based on principal elliptical burst movement. And this is indication for rotablation. Coronary lesion with a very high severe calcification, long diffuse calcified lesion, ostium lesion, CTO, a small vessel, instant restenosis. But it is a contraindication, like the lesion with the soft plaque, especially with the thrombus, is indication for the rotablation or curtain balloon. This slide shows the efficacy and safety of rotational atherectomy compared with the balloon BOBA You see, 30-day mortality, 30-day MACE, angiographic restenosis, compare, it's the same. No difference, no difference significant. Yes. Compare. So, but we view the rotablation atherectomy. You see, we see this. There is some complication. The most interventional cardiologic must pay attention. And the complication relate to the learning curves. At beginning, it is easy to have the complication. The complication related to the rotablation, we call death, MI, urgent CBG, dissection, perforation, but slow flow from the lot of SE not field. You see, it's the assistant in the when we use the rotablation. The doctor may pay more attention when we use atherectomy. Atherectomy is either based on the balloon device. We usually use casting balloon, scoring balloon, sometimes a very popular device which commonly used in treating mildly fibrotic calcified coronary lesion. Casting balloon and score balloon might control micro incision in the arteriofibrotic plaque at low pressure, reduce appearance of uncontrolled longitudinal tear. The casting and scoring balloon sleep less than conventional balloon, so maybe useful for treating restenosis or osseous lesion. It is three types of the balloon used in the atherectomy. The first, the chocolate balloon. The second is a custom balloon. Three, the score balloon. It design and composition of custom balloon or score balloon consists of the first character, the second is a balloon, the third it is the plaque. Very important. Very important. Usually very small, very tiny plaque, or the wire make a tiny incision when we balloon up into the vessel arterial plaque. When you see the mechanism of action of cutting balloon is referred to atherectomy. When we the balloon go up, the plaque score in the plaque create in a small incision for crack prolongation. Atherectomy create microcervical incision and score at vessel wall. Besides, the custom balloon reduce the appearance of uncontrolled longitudinal tear in the vessel when the balloon up. So limit the dissection when we balloon up. This is the angioscope scoring balloon, the same with the two rectangular wire together around the balloon. But it's when we use the angioscope scoring balloon when can go up the 16 atmosphere. When we use casting, only the 12 only. The score flight is the design of score flight balloon we can use in my catalog. And it is the casting mechanism of casting balloon and the scoring balloon. You see, the next we talk about the efficacy and safety of the casting balloon when compared with the BOPA. The casting balloon, casting compared with BOPA, casting or scoring in clinical trial failed to prove consistent long-term benefit in terms of restenosis and major cardiac events. You see, it's only when we use the custom balloon or the rotablation, a scoring balloon, the the procedural success of PCI is higher than the BOPA. Yes. And it is some example in custom balloon in small vessel. This is the key conclusion in custom balloon device used in small vessel, reduce vessel stretching and injury by scoring the precise dilatation, maximum lumen gain by plug compression using lower pressure, good result as standalone therapy. The second, we can use resistant lesion, especially in the ostium lesion. It's reduced elastic recoil, more plug compression with minimal plug shift and less vessel stretching, maximize lumen gain, and prevent the yield cypran when we use the provisional distance in bifurcation lesion. It's in a bifurcation lesion. It's prove better outcome with BOPA, but maximize lumen gain with minimal plug shape. Và custom when can use and vessel, ostium vessel, because in the ostium vessel lesion, the lesion usually fibrotic, elastic, and core complication because recoil and spasm. So the solution for that, you use custom balloon, reduce elastic recoil, more plug compression, but less wall expansion, maximize lumen gain, but better score. In bifurcation, the same. You see, for inclusion, the atheroablative device consists of atherectomy device and atherotomy device based on casting or scoring balloon, often make plug modified. The use of the atheroablative device have found contemporary and facility role in the treatment and heavily calcified lesion, osteolysis, bifurcation steno, and dilatable lesion, especially for heavy calcified lesion. Atheroablative procedure do not lower complication and reduce restenosis when compared. So it only the supportive measure for stenting before stenting implication, especially for the DES implantation. Utility of most atheroablative device require advanced technical skill should be adhere to some important principle in operation to avoid severe complication. The operation requires a special training because the complication related with the training course. And the first thing, the cardiac surgery backup is always needed when we use the atheroablation device, especially rotation device. And the first thing I always remember the proverbs in the medicine. The first thing in intervention is do not harm to the patient. I always the case. It's the proverb. It conclude. It is my concludes my presentation. Thank you for everybody to listening. Yeah, thank you very much.
Thank you very much for your very good presentation, Dr. Nguyễn Thượng Nghĩa from the Chợ Hospital. Now we have a time to some discussion from the panelists. So the first question I want to ask Dr. Quan Ly. Can you share your opinion about the atherectomy balloon for the calcified lesion?
Yeah, I think it's obviously it's a great idea when you, especially with cost is an issue. I personally find that I prefer the Wolverine versus the endoscope because a lot of calcified lesions, one of the main problems is your ability to deliver the device to start with. Obviously, if you properly prep it and you can get an angio score down, an endoscope, it provides definitely more surface area coverage to generate the scores. But the Wolverine has definitely improved performance compared to the last generation of cutting balloons. So for me right now, my favorite balloon, if I'm going to use a cutting balloon as a initial strategy or a post-rotor strategy, is to use a Wolverine. I think with lithotripsy coming about, there is a potential future change in strategy if we can prove that the lithotripsy does not damage the polymer. You know, after all of this stuff, a lot of times if you just put a stent up and dilate to very high pressures, a lot of times the stent will expand. And I suspect that maybe in the future, you can put the stent across, and if you get any stent regret, then you use lithotripsy, you know, and then you're done.
Yes.
And about 30, then what you'll find is that maybe only 30% or 40% of the cases, you actually need to use a device if you can deliver the device to start with. It's a very interesting idea, and I'm not sure, obviously that will require a very specific clinical trial to test the question, but it may be a way to save money overall, you know, so we don't always have to use atheroablative devices.
Yes. Thank you very much for your sharing.